The webinar is live.
Thank you very much. Hello to everybody. My name's Andrew Wilson. I'm the chair of Cheshire CCG, and welcome to the governing body meeting for Cheshire CCG. As we have become accustomed to, this is a meeting which we are holding virtually because of the coronavirus pandemic. As always, it's a meeting which is being held in public rather than a public meeting, although we do invite public questions to the meeting received in advance. On this occasion, we don't have any public questions. I've remind my colleagues to stay on mute whilst you're not speaking, and to use the chat bar to request to speak as part of the meeting, as we have all become accustomed to. We are again having a meeting during the pandemic. All of our meetings so far as Cheshire CCG have been during a pandemic, but I think it feels like a particular time in a pandemic for them at the moment, doesn't it? In that the pressures on health and social care do seem to be horrendous, and the demand is outstripping the capacity of the system to deliver what the public expects and what people want to deliver on many occasions. I think that's something that we probably need to be honest about and recognise, but also recognising there that there is tremendous work going on across health and social care. There are good news stories all over of people getting great care despite all of the difficulties that everybody is experiencing. Unfortunately, there are also, as we often hear by the media, bad news stories about people not getting the services that they need or sometimes that they expect to be receiving. And in many cases, I think we can understand why that is occurring. But I think what I suppose I urge is that whilst that is understandable, I don't think any of us think that it is acceptable, and we want to be working to improve things. So I think that's almost the theme of many parts of our meeting today, particularly around the performance. And we will hear about the pressures that there are within many sectors in the hospital sector, within general practice and primary care sector. One sector I particularly wanted to mention, not directly our responsibility, but the care sector, which is under tremendous pressure, particularly with workforce issues, and is such an important part of the whole system. And the other theme that we will hear about in our meeting today is about integration, and how we need to be working together, and how we all need to care about care as much as we care about hospitals or primary care or any other part of the system. So just a few thoughts about that and about the pressure the systems and services are under, but we will talk much more about those as we move forward. So if we move on then with our agenda, to our apologies. We have apologies from Ian Ashworth and Matt Tyra. Christine, are there any other apologies we need to make? I'll take silence as an absence of any further apologies. So that leads us then to item 1.2, which is declarations of interest. Relevant to the agenda, all governing body members publish their declarations of interest on our website. So this is an opportunity for colleagues to either add anything which is missing from their declaration, or to highlight anything which is on that published declaration that is particularly relevant to the agenda today. I will give us all something of a conflict of interest in that we are on a number of occasions discussing a movement from when we are now to new structures within healthcare, and with the bill going through Parliament that will abolish CCGs, we all have an interest in that and are all conflicted to a degree in that. I don't think that's something we can mitigate other than that to remind ourselves of the Nolan principles and our duty to make rational, objective and selfless decisions under those guidance. I don't see anybody wishing to declare anything, so we'll move on then to the minutes, which are item 1.3, which is on page 3 of your pack. So we can start at page 3, page 4, page 5, page 6, page 7, page 8, page 9. Nope. I'm just allowing a little bit of time for people to type in case anybody's got any queries. Okay, brilliant. I think we've got a acceptance that they are a reflection of our meeting without any corrections. So thank you very much for those. Although Matthew, I think you were going to make a correction, I understood.
Sorry, Andrew, I was just trying to type at the same time, but it's too quick. So going to make some slight amendments to the minutes section that references our response to the question raised by a member of the public at the last meeting. It's not as accurate as what we responded directly to the individual, so we'll make amendments to that minute to reflect that.
Okay, lovely. Thank you very much. And I'm taking nobody else as. I'm just pausing in case anybody else was trying to type and hadn't had the opportunity. Lovely, thank you. Okay, that takes us then to item 1.4, which is matters arising or actions, and previously notified any other business. So I don't see anybody wishing to raise anything from the minutes. We do have an AOB, which we will probably come to partly when we discuss the quality and performance, but we can probably have a response to now. It's Dr. Afton has raised this, and it's regarding the shortage of blood test tubes, which are causing additional pressures in the system, and making the point that some practices are running particularly low on blood tubes. And I understand that Dr. McCalvey or Dr. Clark might be able to give us an initial response to this before we pick it up later. I don't think neither of them are on, are they? We'll pick it up at on the quality and performance report. So apologies, Leslie. We will come to your AOB, but it will just come to it later. In which case, we'll go to section 2.1, and I'm pleased that this month we do have a patient story. So we have a video which is about social prescribing, and just as a bit of background, social prescribing is available at across all practices in general practices across Cheshire, and a social prescriber is somebody that can guide people to the services that are available to not necessarily directly healthcare, but around supporting care that might be social or psychological or emotional, whatever is needed to help somebody around getting better. So could we share that video, please?
Hi, my name's Nikki. At the end of in December 2020, I was in a very dark place and took a major step in calling the doctor. Never felt like these feelings before. So with me speaking to the doctor helped me with medication, but also then asked if I would be interested in speaking with a key worker, a social prescriber. Not sure what that was all about, and I agreed because I just wanted as much help as I possibly could. And the doctor then passed on my details, and then a lovely gentleman called Andy, who's a social prescriber, called me up, and I spoke with him. At that time I was not knowing what to say, very anxious, not a very nice place to be in, and opening up and speaking with somebody before I spoke to the social prescriber was just like, what can I say? What can I do? I don't know how I feel. Very quickly, I was put straight at ease, and then it very quickly I realised that it was the best thing that the doctor could have done for me. This was the start of my journey, which was long journey and very hard, but in the end very rewarding. When I called the doctor, I'd been off work for 8 months with labyrinthitis, and because of with COVID, I wasn't able to see a specialist, and the longer I left the symptoms, the worse I became, where I wasn't able to speak properly, sleeping all the time, couldn't move, put on a lot of weight, feeling very low and anxious. So because I felt so low and so exhausted with the labyrinthitis, everything just came ahead and I ended up very low. And that's what got me to call the doctors up. And because with the social prescribers, it's like as if they're your friends sitting in your living room and you're just having a general conversation. What he got out of me is more than what a counsellor that has ever had out of me. Was for me to be able to then look at lots of different issues that I didn't realise that I had over the years. I was able to face them. Andy was just amazing. He literally just got everything out of me. But with that, I was able to find who I am. Yeah, it was, wow, even now, it's good tears. So powerful. I would just gave myself the smallest little tasks and reaching these goals and making me stronger each day. I spoke with my key worker every week. While I was speaking with him, he actually put me also in touch with, because then when you're having a conversation and then he picks up certain things, like with the anxiety and things like that, I was offered a mindfulness workshop. And then also with me being off for such a long time and I was immobile, I put on a lot of weight. So with that was making me low. He also then asked if I'd like to then speak with Emily, who does a weight management program. And again, lovely. So just by calling the doctor and they're putting me in touch with Andy, I then was in touch with Francesca and Emily to do with the mindfulness, and I realised later on as well, you don't actually need to go through your doctor. You can just go through the doctor's reception, through the receptionist at anyone's doctors, and they can be put through to a social prescriber. Social prescribers for me has just been like my lifeline. It was just literally just did so much. It made me find myself. But the biggest thing is it made me see who I am as a person and love myself for the first time. Okay, how far I have come and what it's done for me, huge.
So thank you for that. And I think we'd all want to, in particular, thank Nikki for making that video, which was clearly emotional, and sharing those things is not necessarily easy. So thank you very much to Nikki for agreeing to do that and for sharing in that way, because I think it is very, very powerful. And I'm sure it's going to have a very positive impact on people who listen to that, who might need that care, and help them to seek it in that way. I'll come to anybody who wants to add anything. I'll come to Dr. Rees in a second. I see he's put a comment on. But my initial thoughts about that were how I got a real sense that the service that was being offered there was very person-centered. You very much got the feeling that Nikki was in the driving seat, and that her needs were really being met. This wasn't a service that said, we can do A, B, and C. Do you want A, B, and C? It was a service that was saying, what can we do for you? What can we help? And it really felt like she was at the center of what was happening there. And that the person that was there was learning from her what her needs were and how then they could assist them. And I think that's probably a lesson for us all. And if we can get more of our services to act in that way, how much more effective would our services be? Is something that struck me and reflected on. Gwydion, do you want to come in, and then we'll go to, I think Peter's got a comment.
Thank you, Andy. Just to say, a brave video, and I think it was really powerful when she said that it allowed her to see who she was and care and love herself, for the first time. I thought that was brilliant. I may have mangled her message slightly there, apologies for that. And yeah, I think it's just important about that person-centered aspect. You know, she named the people that cared for her. It was appropriate to her and it was close to her. So no, lovely video, thank you.
Thank you very much, Gwydion. Peter.
Yes, thank you, Dr. Wilson. I was equally moved by that presentation, and a very brave thing to do, to come on, and probably some testament to the confidence that she's managed to get back. I know there's some really good academic evidence for social prescribing, and I think it's something we should be doing more of across the NHS. But I was just, my question is, I believe this is a PCN-based service. What percentage of our PCNs can offer social prescribing right now?
I don't know if anybody has an absolute 100% answer to that. I can see Neil going towards his microphone. Neil?
Yeah, I don't immediately have the percentage figure, but we have that information around who's got social prescribers, so we can share it immediately after the meeting with the governing body. I can ask someone to send the latest table of who has social prescribers and all the other additional roles reimbursement scheme in place across the PCNs.
Thank you.
Thank you very much. I did. Nobody else is offering to comment at the moment, so I did want to just add one thing. It's widening out the aspect really into wider primary care. And there's been a lot of discussion in media recently about the pressures in primary care. So I asked for some of the latest figures we have across Cheshire, and it was just to let the governing body know that the figures are actually for a rolling 12 months to August, that across Cheshire there were 1.8 million face-to-face consultations with GP teams and 1.4 million telephone or video consultation with GP teams. So it's a total of 3.2 million consultations for our population, which is seeing the equivalent of the entire population of Cheshire about every 12 weeks. So fairly substantial amounts of activity which are going on. I think we have all heard and seen the media reports, and some of them are not very complimentary about GPs, but it's just to reassure our public that our general practices are open. They are seeing large numbers of people. That is a combination of face-to-face and telephone and video for reasons of infection control and others. But people are open and they are seeing people face-to-face, and all of our practices across Cheshire are doing that. Thank you very much. If there are no further questions, we'll move on from the patient story to the public question and answer section, although I understand there are no public questions for this day. No, today. Thank you. So that takes us then to the chair's update, which will be brief. So we haven't done a written report on this occasion because there isn't a huge amount to say. Not that I've not been busy, but I have been busy. But I think most of what I've been busy with is picked up on our agenda. So most of the work I've been doing since we last met has either been at place and discussions about new arrangements around place and how we best integrate across health and social care and within health around our two places, which is Cheshire East and Cheshire West, on the local authority footprints. And of course, we know there's a bill going through Parliament that when it becomes an act will establish CCGs and will move to becoming an ICB, with those places becoming important delivery units within the ICB. So I've been doing a lot of work talking to colleagues and partners around that, and I've also been doing work at the other end, which is the Cheshire and Mersey level with the joint committee, where we're working towards bringing together some of the functions of the CCGs to allow for a sensible, safe landing of CCG functions into an ICB and the new world from April 2022. Other things to mention is that we do have membership meetings coming up with an expectation that we'll be discussing place, new arrangements and joint committee, and the continuing work around GP Confederation, which is happening particularly in Cheshire East, but earlier conversations in Cheshire West about that, and about evolving the engagement that we have with our member practices, and talk about how we evolve that into a new world to ensure that practices remain involved and engaged and active in improving things for a population, on our population. That's all I intend to say. We'll pick up those main themes in other parts of the agenda. So I'll just pause in case there are any questions. There aren't. Just a word of news, Dr. McKelvey is trying to join us, so he might be able to answer something about blood tubes, but he's having technical problems, so he is trying to get on. Okay, thank you very much. That moves us then to section 3.2, which is the Accountable Officers Report, which is on page 10 of your pack. Good colleagues will have the opportunity to read it. Claire, the things you wanted to highlight from your report.
Yeah, thank you. Good morning, everybody. So for me, the report this month is sort of really in two parts, very much about preparing ourselves for the future as an organisation and an employer of 334 staff, with a national policy, as Andrew has referred to, in terms of establishing CCGs from April 2022, but also about the continued work that we are doing in terms of commissioning, quality, safety, and service improvement and delivery. I really want to assure the governing body that it's not just about planning for tomorrow. It's absolutely the here and now in terms of what we do, in terms of our core business and what we're here for in terms of ensuring the best services for our population. I guess with that, I was at the LMC yesterday and they asked me to provide assurance that the CCG exec team, myself and others, you know, were absolutely sort of cognizant of the pressures, today's pressures, and that we were prioritising that over, you know, structural and governance reform. And I was able to do that, and I think sort of provided some confidence. And I guess in terms of even just being able to outline sort of the previous 24-hour meetings, they weren't about governance. They're about, you know, the exec team are now meeting weekly to talk about escalation pressures in the providers. We had A&E Delivery Board, Health and Wellbeing Board at Cheshire West talking about the environment and economy, regional primary care meetings, letters to MPs and COVID. So absolutely today's business, as well as planning for the future. So I think that's what the Accountable Officers Report does this month. So I'm not going to go into too much detail in terms of most of the items, because you can see there's updates on community services, on EPRR, on spinal, on SEND, and obviously a great report from Cheshire East in terms of we've made sufficient progress, so the inspector can now sort of move away with confidence. But obviously we're never sort of complacent in terms of that work, in terms of our vulnerable population. We want to do it as well as we can. We will keep striving for the future. You can see in intrapartum care, we're hoping those services will be back at Macclesfield this side of Christmas. There's further work to do, and we're engaged in that work, working hand in hand with the Trust and the regulators. I do want to pick up on, as usual, the usual COVID update and the vaccine programme. Fantastic performance as usual in terms of 86% of our over 18 population have had their first vaccination, 79% have had their second vaccination. As ever, this is about partnership working, and we say this every month and whenever we can, but it is a massive thank you to everybody engaged in that. All the providers, all the partners and the volunteers and the stakeholders. You'll know there's the Evergreen offer, so if you haven't had your vaccination, please go and get it. Make sure you get your second vaccination. I think since the last meeting, there have been developments around 16 to 17-year-olds. You'll know in the press around 12 to 15-year-old children, and the booster campaign. So there'll be a mixed and blended offer of providers across Cheshire to ensure that we do the right thing by our population and keep everyone as safe as possible. So what I wanted to talk about really is some of the guidance that's come. We've talked about, and I think Linda's often said, and I keep repeating this, so I'll stop now, in terms of an avalanche of guidance. So you can see that that is attached to the report. You'll be not surprised to know there's more due today and tomorrow, I think. So there'll be more for us to read and wade through. We will send out a helpful slide deck, which has got sort of really quite helpful summary of each of the guidances. But I think for me, they're almost like sort of three parallel streams. One and in the guidance. So there's a whole raft of guidance around partnerships, people, communities, social enterprise, and all of these sort of the wider determinants. And that's very much for me what an ICS is all about, an integrated care system. So it sets out the ambitions and expectations of an ICS, but also of places in terms of place-based partnerships. And I think that's what we want to drive and strive for in Cheshire and Merseyside, but with our 2 places. And it's absolutely critical for the success of place that we follow those. There's another strand of guidance which is around governance, loads of acronyms. So, you know, again, we need to sort of think about how we ensure that everyone understands what we're talking about in terms of ICS, Integrated Care System, ICB, Integrated Care Board, and ICP, Integrated Care Partnership. That is at a Cheshire and Mersey level, but then we have to look at the governance in place. Our 2 places in Cheshire, Cheshire East and Cheshire West, on the local authority footprints. We need to make sure we have the right governance in place locally from the 1st of April, so that we can take on as much authority and autonomy from Cheshire and Merseyside as possible. There's places that people talk about primacy of place, and we know from the work we've done to date that that's where we want as much authority to be. So that's the second strand of guidance that's come out to date. I think that the third strand, and I think for me as the accountable officer of the CCG, this is as important, and this is around clinical and care leadership and the HR framework. As a membership organisation, we have been absolutely, adamant that clinical and GP leadership is front and centre of the CCG. And when we merged the 4 CCGs into one, that's what we wanted to do. So there's guidance on clinical and care leadership, which is absolutely vital for the future. But then also the HR framework. It probably doesn't answer all the questions that all the staff have, and everybody has, but it answers some of them, and it does sort of set us on the right path for the future in terms of how we support our staff, particularly in the safe transfer of our staff into the ICB from April. I chair the Cheshire and Mersey HR and People group, which is sort of overseeing the safe transfer of staff and assets into the integrated care system. I got integrated care board from April. So I think this framework's really helpful. We're going to be doing briefings to our staff over the next week, so we'll be recording those and sharing that. The other thing I wanted to give governing body assurance on, as well as the, I suppose, all the national guidance, is that we're making sure that we locally sort of look after the safe transfer of assets. So have established a closed down and transition group, a little bit akin to the working together across Cheshire when we merged the 4 CCGs into one. So a programme approach to make sure that we cover and include all aspects of CCG business in terms of that safe transfer. So you can see the details about that in the paper, and happy to answer any questions about that. That will run in parallel and complement the work that's going on at Cheshire and Merseyside. A new Cheshire and Merseyside transition board is being set up, which will oversee sort of transition at scale at Cheshire and Mersey level. So our local group and that Cheshire and Mersey group absolutely cover off all the issues and all aspects of CCG business, so we can assure you about that safe transfer. So I'll stop there, Andrew, if that's okay, and happy to take any questions.
Thank you very much. Any questions for Claire on her report? So Leslie?
Hello, I'm Leslie Appleton, Governing Body GP. Thanks for that report, Claire. It's really comprehensive, as per usual. I just wanted to ask about the sort of, obviously we're looking at the sort of, you mentioned about the COVID sort of boosters in the autumn, and obviously we want the uptake to be as fantastic as it has been for the first and second vaccines, and I suppose that we're finding that often people want to have their vaccines close to home. So and with the fact that PCNs are having to provide a flu vaccine campaign as well, I just wondered what the support was that the CCG were offering to try and encourage PCNs to be involved in this, because we want as many people as possible to be vaccinated. The other question was with regards to the SEND special educational needs that you mentioned. Just a plea really that there is a robust referral pathway and that everyone is aware of what that is and how that's going to work, so that parents are not sort of being pushed one way or the other, either to the schools or to primary care incorrectly, so that is robust moving forwards. Thanks.
Thank
Claire,
you.
before we come back, could I take the question from Chris and Pam, and if you can make some notes and then come back at the end, that might be more efficient, if that's okay. So Chris, would you like to go in? Chris, I think Chris is frozen. So Pam, do you want to come in and whilst Chris unfreezes?
Unfreezes, yeah, thanks very much. Thanks Claire for the update on the new ways of working and new organisations, because I'm very aware from speaking to the public and some press as well that there's a confusion between what's an ICS and what's an ICB and what's an ICP. So that's really helpful, thanks. My question's actually on your PEDS 13.1, your workforce stats. And I'm still confused about female to male ratio. I don't understand that as a number. So if you could explain that to me, that would be good. And can you also explain to me what a planned leaver is? I'm assuming it's someone who has resigned, but then the figures are very strange. If we've only got 50% of people who plan to leave, what happened to the other 50%? So if you could just explain that, that'd be great, thanks.
Lovely. Chris, if Claire's making her notes, I'm giving her quite a task here, but Chris, do you want to come in and we'll go to Claire?
Thank you. Chris Lynch, co-opted lay member. I've just been looking through the guidance, in particular around working with people in the communities, and I have to say, you know, I'm really impressed by what's in there, particularly around, it's mentioning co-production, in particular, considering employing people with lived experience to enable others to co-produce, and I really think that that's the right way forward. And I think especially putting the voice of people and communities at the centre of decision making and governance at every level of the ICS. And I guess what I'm saying is that there's so much guidance that this could get really lost in it, and lots of it just consider. And I think that really trying to do that at the beginning of this process rather than leaving it till the end will just bring better results, and it just sort of urge that we use our voice as much as we can to make sure that that really starts at the beginning of the process. Thank you.
Thank you for that, Chris. Claire, did you make good notes?
Well, I've made notes, but let's see. So in terms of COVID and the booster programme, Leslie, what we're looking at is probably more of a sort of a blended offer. So we have a number of community pharmacies who are providing vaccines, already have, but more have sort of signed up for the booster programme. Most of our PCNs have opted in. We have roving models, we have that. So we have a range of offers and as close to the population as possible. We've learnt in the latter stage of sort of phase 2 that actually taking the vaccines to the population gets the best outcome, particularly for those underserved areas. So absolutely, I mean, we are, if not the best, second best, or one of the best in Cheshire and Merseyside and the Northwest. So we want to maintain that high level of vaccine delivery. And absolutely, the booster is vital for the protection of the most vulnerable in the first instance. So recognise how busy general practice is, particularly with the flu campaign. So I think with that, we have looked at other providers, but going out and reaching the population as much as possible. So I hope that answers that one. In terms of SEND, it's a recognised process for SEND, as you know. Lots of different partners and agencies involved in the delivery of SEND. So I think it's making sure that all partners know their role in that pathway, and don't sort of push one way and the other, but do their responsibilities. And absolutely, these are our most vulnerable children and their families. So it's about providing the right support, and I guess pulling in a bit of what Chris was saying in terms of co-production. And if you think about sort of gunning principles, get people involved early doors and you get a much better outcome. So that's the sort of approach we're doing, and that sort of came across in the revisit at Cheshire East, and I know in terms of the preparation for a Cheshire West and Chester visit, which will be imminent in terms of an inspection. There's an awful lot of co-production engagement with families in that, so they can help and advise the professionals in terms of what's the best pathway and best service for the population. In terms of the ratios, Pam, it is there in Cheshire CCG there are 3.76 females to every male employee. That's what it means. I think that's clear, hopefully. And in terms of a planned leaver, that's somebody who we knew was planning to leave, and who, so there'll be some leavers who've taken decisions to move on that we weren't aware of. So it's about having worked with their line manager and made it aware to HR that that was their plan. So that's the difference. Okay, thank you.
Thank you very much. I don't think there are further questions, so we can move on.
Thank you.
We can report. No, it seems like we can move on. And so we're moving on into item 4.1, which is the governing body assurance framework. So I'm going to hand over to Matthew. Of course, the governing body assurance framework always is an enormously important focus for us, but I think it's going to be more so at a time of transition. I think the risks are things we need to be particularly aware of, and whether we are delivering against that that framework that we set out some months ago. I've spoken to Matthew, and we're hoping to focus on the major risks and their mitigations, and having a debate around those risks and mitigations. So Matthew.
Andrew, just before I start, I noticed that Christine had asked whether she could ask a question around staff well-being. I don't know if you might have missed that one.
I thank you very much. I had missed it. My apologies, Christine.
Oh, no problem. Thanks, Matthew. It was really clear, just to say that we look forward to receiving more details about staff wellbeing plan in our next meeting. But just to ask, whether wellbeing conversations are happening across the organisation, as clearly there'll be a really good way of supporting staff throughout what is a difficult time of transition, as well as over the winter period.
Thank you. Sorry, your question too, so apologies for that. So yes, we'll be bringing more information back next month. Absolutely right. I mean, wellbeing conversations are part of good line management, part of people's sort of PDRs, and obviously something that we encourage, and obviously as part of the sort of NHS people plan, something we're required to do, but it shouldn't be a requirement. It should be part of our day-to-day management. So yes, can assure you on that. We'll bring something back, and absolutely, in light of all the changes that are going on, we know our staff are, in another sort of cycle of change, and we want to do as much to support them as possible. So I've spoken to our OD partner, and we're looking at sort of rejigging the OD framework and making it more responsive to what our staff want, and probably sort of reducing some of the offers and focusing very much on change, resilience, well-being as a priority. So we're looking at that. Obviously, we've got information there in terms of the staff survey. We're doing temperature checks. So we will be as responsive as we can. All of the directors will take this incredibly seriously, and are working with senior leadership team as well in terms of how we support and work with our staff, but recognise that inevitably, there will be some sort of additional pressures on our staff, both in terms of the volume of work and just sort of what's happening in terms of change. But yeah, I'll bring something back next month, but thank you very much for raising it.
Thank you.
Thank you, Christine. An important thing to raise. Matthew, back to you, please, for Gabath.
No worries. Thank you, Andrew. Matthew Cunningham, Director of Governance and Corporate Development for the CCG. I'm also joined by Bill Meakin here, who's the Associate Director because Phil's heavily leading on a lot of the strategic risks. So to field any questions, he might be able to help us on this one. So just to take your early point, Andrew, I won't go through each item in great detail, because I think people will probably want to ask questions around certain risks. But I just wanted to highlight a couple of things in the report before we might want to focus on what we feel is the three biggest risks, really. You will hopefully have read throughout the report the work that's been underway around the change in the governance structure, which is reported later on in this meeting, and the plans going forward around managing the governing body assurance risk. So I wasn't going to focus on that in this particular section, but we can pick it up later on in the other paper. But as we've even not had committee meetings, we've highlighted the process we've done to try and make sure we've kept on top of the strategic risks, engaged with the committees, engaged with the committee chairs and the risk leads to make sure we're getting an update picture on what we think the risk score should be for the assurance framework. I caveat that with that it's a moving feast all the time, and we've already talked about, you know, some of the pressures that are impacting all aspects of health and care today, and that does get reflected in the operational risks, which in turn then filter up to impact on the strategic risks. So I recognise that what we agreed when we were writing this report 2 weeks ago in some respects, or a little bit longer, might not necessarily with what you're feeling today. But we have to recognise equally that the governing body risks are usually very high level strategic risks rather than just the operational risks that we rightly focus on as well. What I wanted to highlight really is that there is only one suggested or proposed change to the governing body in terms of risk score, and that relates to risk number 11 in terms of being unable to plan or have resources and procedures in place to react and respond to the challenges a pandemic brings. And we're suggesting the target score is reduced from 20 to 16. And that might be something you wish to debate if you don't agree with that. We've also highlighted in the report, as we committed to previously, to highlight the top operational risks. So, please, you know, in Appendix B, you will see them. And hopefully when you've gone through the governing body assurance risks, you've been able to see where these link into the strategic risks as well. In terms of, you know, did ask me what do you feel are the top three risks, and I would open that up equally to the governing body and fellow execs on that one. But if you go by the scores, then we are saying currently our top risks are risk 1, 7 and 8, which is either failure to design and commission environmentally and socially sustainable services. The CCG is unable to deliver a balanced and sustainable financial plan, and our inability of providers and partners to effectively deliver the standards of performance we have agreed based on national and local priorities. So they are currently our three highest scoring risks, but I appreciate you might wish to discuss that as well. So Andy, if it's okay with you, I will open up to questions if anyone's concerned, because hopefully you've had a chance to read the report. Hopefully you can see what has changed since the last time you saw this in the previous quarter. And between myself, Phil, and the risk leads here, hopefully we can address any governing body questions.
Thank you very much, Matthew. So let's open that up. So those are the three risks that Matthew has pointed out, fairly between them, fairly substantial. So I'm opening it up for a discussion, particularly around those risks, the mitigations which are listed, and the governing body's assurance on those mitigations. So Leslie, to start off, please.
So mine's not necessarily related to those risks, although I think I want to comment on the sort of procedures in place to react to the pandemic in a minute. It's the risk of failure to attract and retain staff that I just wanted to focus on, just because as we move towards the changes that are coming into place in April, actually this is probably going to get worse, that staff are unsure and uncertain about whether their jobs are going to be present and are going to be looking to move on really, potentially. And I suppose this relates back to the sickness record as well, which is heavily weighted towards stress and anxiety being the issue. And I feel that if you're losing more staff and you're not able to bring them in, that stress level is going to increase and potentially you're going to have more staff going off sick. So I didn't whether that risk, obviously it's not a risk to patients or care, but it is a risk to the ability of the CCG to function during this short time before we move over. So that was my first point. The second one was, I suppose, the uncertainty around the pandemic and what is going to happen over the next few months, that the rates are rising, hospital admissions are increasing a bit, and I just feel that sort of moving to a level of 16, is that sensible before we know exactly what's going to be happening? But I'd be happy to receive any other governing body comments about that and how they feel. Thanks.
Thank you very much, Leslie.
Andrew,
Do you want to respond to that, Matthew? Whilst people,
I can give a response, but there's more than me, I think, that will want to respond to this. I think Claire's wanting to respond.
Yeah, do you want me to, if I go first, because in terms of being exec lead, so absolutely, Leslie, in terms of the risks around staff, we had in the previous my update in terms of the wellbeing conversation. So we actually had a conversation about this at the exec team earlier this week. So we're doing a deep dive into why people are off with stress and sickness, and to understand better the figures, and obviously looking at the support we can offer. And recognise that if somebody's off sick, it has an impact on the rest of the team as well. So it's sort of almost a sort of a double sort of hit in terms of the individual and the team. I think the fact that the employment commitment for staff below board level has given some confidence to staff in terms of the future. Obviously, the CCG going into, establishing and going into the ICS as the successor organisation. So staff below board level will have had that sort of confidence for some time now, and the HR framework nationally sort of commits that. So in terms of that message, we've been working really hard with our respective teams to give them that confidence of the future. Obviously, where they sit, they will be aligned into the ICS and then be aligned back into place in some cases, and some will work at a Cheshire and Merseyside level or other. I think a lot of our staff are involved in the work of the ICS, and that's giving them real confidence and opportunities for the future as well. So I don't think we should automatically see the ICS development as negative in terms of individual career development and personal development. A lot of people are, as we're calling it, leaning in, working into the ICS, working on the agenda, and as we've referenced earlier in the meeting, really leading some of that work on behalf of Cheshire and Merseyside. So I think that's popular, but I think we're not complacent. We're absolutely, we're keeping an eye on all the figures, all the staff, all the time. We're not recruiting. So, we are looking at recruitment of vital key posts and looking at how we can manage across the directorates, and also working more closely with our local authority and provider colleagues. So in terms of preparing for the future, we're looking at some joint posts between ourselves and the local authorities. Sometimes we're looking at posts with some of our providers to look at new ways of working. So I think we're not standing still despite the change that the ICS is bringing, but absolutely in terms of supporting our staff and giving them confidence for the future. I hope we're doing that as well as we can. So that was the first risk. And I think in terms of the second one, yes, rates are going up, hospital rates are going up a small amount, but I think the key thing is the vaccination programme is working, keeping the population as safe as possible. So I think the recommendation in terms of reducing that risk is more about our knowledge and how well we've planned our COVID and vaccine campaign, and all the work with partners around the COVID campaign in general. So that's the recommendation. I mean, obviously, we need to take the sort of views of the governing body, whether they agree with that reduction. But I think it's very much about, we've been doing the planning and all the sort of the work around COVID for 18 months now. So I think that's about how well placed we are to deliver the rest of this organisation's agenda alongside the COVID campaign. So I think that's why we sort of felt confident to reduce it. But obviously, look, we need governing body support for that.
Thank you very much. I think Phil is offering to respond about the pandemic point as well, to add something to that. So Phil, can you do that briefly? And then I'm going to go to you.
Thank you, Chair. And thanks for raising that, Leslie. Yes, I mean, it's just to support what Claire said in essence. I mean, the risk articulates being able to plan for the pandemic. And I think we've demonstrated a couple of things over the last year or so, which is the required governance to support that planning and preparation and response. So the COVID group, bringing reports to the governing body to provide assurance. And also, Claire and the exec team were threaded into the local, what's called the local resilience forums at Cheshire Warrington level. And I think that really gives us an inside track into sharing best practice and leading the way in terms of that response. So certainly as the kind of the risk lead for this, I took a report to the COVID group, with that rationale, and it was quite well supported from CCG execs and also the Integrated Care Partnership colleagues who are also on the CCG COVID group as well. So just wanted to give some assurance on that, Leslie, really.
Thank you very much. Fiona, you have a question.
Hi, yeah. So I've got three things I wanted to say. One was just in relation to what's just been being said. I would encourage the idea very much of these joint posts with local authorities and whatever that was being mentioned there. Just with a view to my other question, which is about finance, I just wondered how that works practically, really, because what we don't want is people having jobs that aren't going to be long term or not sustainable. They sound good for the transition period. Will we actually have our staff who want to do those jobs knowing that they have an ongoing job in the future, as opposed to just to get us through this transition period, which kind of then ties into my ongoing concerns always about finance. I appreciate in other conversations our requirement as a statutory body to be pragmatic and try and make the savings and make sure that we are not profligate. But I still am quite concerned that there will be a gap in the finances, probably in lots of CCGs at the end of the financial year. And I'm still quite concerned about what happens to that deficit, especially because if we're moving into different ICPs, almost two, I have a concern about what happens with the West, because we work across more than one district general hospital. I can see the Vale Royal group of people who I have historically represented being at a disadvantage, because that money is going to be, or that gap in the money, or how the new monies are going to be allocated, is still going to be a problem. And that's my real concern. I mean, partly, will the staff have proper jobs that are sustainable, that they can support their lives going forward with, and then will the people in Vale Royal not be disadvantaged by the fact that there is obviously a deficit, no matter how hard we try to plug it.
Claire, I think you're going to respond.
Well, I'll do the staffing, then I'll leave our CFO to do the finance, if that's okay. So in terms of the staffing, some of the opportunities are fixed term, short term secondments, but their substantive roles remain, and the sort of establishment in the budget for permanent roles exist. So I think, Fiona, it's about giving people opportunities as much as putting people at risk. So I think I'm comfortable and confident about that. And as I said previously, for below board level staff, align a sort of lift and shift into the ICB. So they will have a commitment of ongoing employment. The terms and conditions are the same, but I mean, we don't know what roles will be, but in 90, a large percentage, they'll be doing a very similar role to what they're doing. But in terms of continuous employment below board level, CCG staff will align to the ICB. So I can give that assurance. So Linda, I'll hand the finance one over to you, please.
Okay, so in terms of the ICS and the CCGs and the transfer and the transition, etc., there is, as Claire knows, I often say, an avalanche of guidance, and there will be lots of specific finance guidance about how this happens. But the underlying thing is that the ICS is the successor body to the CCGs. So all of its assets and liabilities, which will include the historic deficit, will flow from the CCGs into the ICS, and it will be held by the ICS. There will then be further rules, etc., around how the ICS and place will operate so that the monies will flow around the system. We are not party to seeing all of that guidance yet, but we know it is on its way. Does that answer your question?
So I think largely from what we can do about it, yes. I suppose I would still like my concern with the system as a whole kind of registered somewhere, because, you know, historically I sometimes feel that when there has been a change, the people who've had the most money and spent the most money then get the next most money. And you know, if we're looking forward to some of the papers that are coming up in the things that we're being asked to do later on in the governing body, one of them is about, do we follow the flow of the money historically, or do we try and spread it evenly across the communities, in one of our papers that's coming up. And that's always my concern, that if we're really tight on this, which is a good thing to be, you know, will our communities be disadvantaged? And I know you can't tell me one way or another. I just would like it noted, I suppose.
Yeah. Okay. Yeah. I mean, there's going to be the monies in the future will flow to the ICS, and then there will be mechanisms and tools to allow them to then allocate the monies into place and into their future investments, etc. And there will be lots of guidance on how that happens.
Thank you very much, Linda. Thank you, everybody, for your questions on the assurance framework. I've got no further interest to speak.
And Chair, I had another question, if that's okay, about number 8.
Okay. Can you make it brief, please? We are quite significantly behind on our time.
Well, again, this is part. I suppose it's just a reassurance, really, because at another point in the governing body papers, and I just can't exactly find it where, we have been asked, not that we don't have to report on lots of the things from our providers that we've had to report on previously, because everybody's working far too hard and they don't want any more paperwork than they normally have to, I suppose, look at NHS England. But it was just, if that is the case and we're not being asked to report as much as we have been in the past, are we still assured, bearing in mind that one of our risks is that our providers won't be able to provide what we've asked them to provide? That makes sense?
Absolutely, it does. I suppose I'm expecting Neil or Paula might. Linda is responding. Linda.
I think either Paula, Neil, or myself could respond to this. We do have a quite robust way of doing this. We are meeting with the providers on a regular basis. We have formal and informal mechanisms for this now. So whilst we have suspended the contracts, we are continuing to do monitoring of performance. I don't know whether Paula and Neil would like to add anything.
Yeah, that's right. I think this was about additional reporting. We've never stopped some of the I guess the key national reporting systems in terms of understanding how long people are waiting for treatment, etc. So we've always had that. This has been about, I guess, that over and above capturing of information and reporting that wasn't adding value. And we are, as Linda says, in daily dialogue with many of our providers about performance challenges and trying to work with them on identifying solutions. So hopefully we can pick that up in the quality and performance paper later in a bit more detail to provide a bit more of that assurance. And those who sit on the Quality, Safeguarding and Performance Committee will probably vouch for the volume of performance metrics that we still include there, which are nationally required, and we could certainly share that with the wider governing body in terms of some of that information flow.
Thank you very much. We will be able to pick it up again later when we have the committee reports. So thank you for that, Fiona. I think we will move on now to the recommendations. And we are asked at page 27 to review and update the governing body assurance framework. We're asked to improve the strategic risk scores, and that of course includes the risk that has been changed from 20 to 16 around pandemic response. So you're agreeing to that, and consider whether the controls and assurances are sufficiently robust. So I'm looking for agreement on those three things. More importantly, I'm looking for any questions or dissent against those 3 points. Thank you. We'll take it that those are agreed. I'm going to go very quickly back to the Accountable Officers report because I didn't go through the recommendations on that. We were asked to note the contents of that report and the current position relating to the temporary suspension of interpartum care at Macclesfield District General Hospital. And we were then asked to endorse the executive team support. I've agreed with Claire that we don't need to endorse that, so we are simply noting the contents of the Chief Officer's report and the particular item around interpartum care at Macclesfield District General. So thank you. So that's the governing body assurance framework. And that takes us forward to item 4.2, which is the long COVID investment in place multidisciplinary teams, which is on page 94 of your pack. Can I remind presenters that colleagues have had the opportunity to read and will have read and digested the paper, and that we're a little bit behind our time. So I think, Tracy, you're introducing this item.
Yeah, good morning, everyone. I'm Tracy Cole, Director of Strategy and Partnerships. Yes, thank you, Dr. Wilson. So, brief synopsis, and then we'll go to the recommendations, if that's okay. I realise time is with us. Introducing Amanda Ridge, who is also on the webinar, and also Dolores, who have both and others have been very much a part of producing this paper. We currently have a service for long COVID provided in Liverpool. 607k has been allocated to Cheshire to make sure that we commission a place-based service going forward. There are 4 options in the paper. The paper has been shared with Cheshire LMC, Health Watch and third sector colleagues as well, so that they can work collaboratively going forward. It's for adults, and we are hoping to commission a service which covers physical, psychological and cognitive symptoms of long COVID going forward. So assuming everybody has read the paper, of the 4 options, the recommendation is that funding is provided to our existing 3 providers who provide pulmonary rehab, but that they are asked to collaborate across Cheshire so that we have continuous high standards and support each other in terms of staffing problems that exist at the moment. So I just want to say thank you to the team for producing the paper. And I think if we leave it there in view of time, only one thing is I just asked Dr. McAlevey if there's anything else he wants to add in support of that from a clinical point of view. Otherwise, I think we'll move to the discussion and the recommendations, if that's okay, Chair.
Thank you. Dr. McAlevey.
Good morning, everybody. My name is Andy McAlevey. I'm Joint Medical Director of Cheshire CCG and the local GP close to Ellesmere Port. It's absolutely imperative we have a local service. I can understand how we did have a regional base service based on the funding, and it was centrally driven. But with the impact of COVID, we absolutely need this. And I think I completely support the model as providers come together and work in a collaborative way, both in health and in care, and using our voluntary sector wisely. So completely endorse Tracy's sentiments and the paper. I mean, it's desperate that we need this. We probably need a bit more. But we're given the resources that we have, so I'm delighted to support it.
Thank you.
Thank you very much. We do have questions, so Leslie, would you like to pitch in, please?
So thank you, Andy. I just basically I have concerns about, I know we can't do anything about it, but the non-recurrent nature of the funding and the fact that it's difficult to get enough staff to actually provide an adequate service. And how we would mitigate that moving forwards, because as the very name suggests, long COVID is not just going to last for a year, it's potentially going to last much longer than this. My other worry and concern is that we're looking at the pulmonary rehab and whether this is a correct place for the funding to be allocated. This is not just a respiratory condition. It affects a lot of organs. It affects people's mental health. Fatigue is a big, huge issue, and it isn't far off what people suffer with sort of conditions such as ME and chronic fatigue syndrome and post-viral fatigue. So I did wonder whether we should be thinking more along the lines of thinking about supporting those conditions alongside this moving forwards in the future, because there's very little service provision for these patients, even conditions such as fibromyalgia. Pulmonary rehab historically in West Cheshire has been a difficult area. I'll choose my words carefully. It's been a difficult area to sort of build up as a service, and I would have huge concerns about allocating all the funding to that particular area, and I think we need to be thinking more outside the box as to how to support this condition. Thanks.
So the details are in the paper, actually, to be honest with you, Leslie, about the MDT approach that we're taking and we're trying to commission as well. So it is about having expertise in those areas with the psychological and mental health support, which is what it's going to be funding. So although it's badged and we've got some support with pulmonary rehab, and that's where quite a lot of the pathologists have been, actually what this is trying to resource is a more holistic assessment. And so that's what we want to try and do. I agree with you about the funding. The funding is tricky. It's how quite a lot of the NHS is resourced right now. I think we're going to realise that the legacy of COVID is going to be long term, and we need to actually look at that. But in the situation we're in this financial year, I think it's a welcome start, and it's actually how we should be commissioning in a place-based way. But actually, I want to affirm that this is much more about an MDT approach to managing patients' presentations and not just the pulmonary symptoms.
Right. Can I bring in Linda, please, who has a question and is going to respond to partly what Leslie raised?
Yeah, so in terms of the non-recurrent nature of the funding, I think this is going to be an issue, and I know I've spoken to Dolores and Amanda and various other people about the non-recurrent nature of the funding. And whilst it's not, if that non-recurrent nature is going to prevent us from actually managing to get anybody into the service to deliver it, then we're almost negating the actual allocation of the monies to the service. So I was wondering if, as part of this, we ought to suggest that the money is sort of almost guaranteed for the following year, so that we can spend up to the same amount in the following year to ensure that the providers are able to appoint people to the service, and whether that is a decision that the CCG governing body would consider taking. Because I think if we don't perhaps take that decision, we will end up not having a service at all, because no one can appoint anybody for 6 months on non-recurrent money.
Thank you. That's an important point which we need to bear in mind, and we'll take with the recommendations. So thank you for that. Suzanne, you have a question.
Yeah, thank you. Suzanne Horrell, lay member for governance. I think Leslie sort of touched on where I was thinking about why are we sort of provider-led on this expenditure and not thinking more about place and locality, and the fact that a lot of people are in the community, not necessarily acute driven in terms of long-term conditions, without being a clinician, I have to say. So I was just a little bit concerned about the approach that was being proposed. And also I wondered, in terms of picking up on Linda's comments about finance and staffing, why we couldn't do something more about a secondment opportunity to people, because otherwise what happens is every time we get funding non-recurrently, we come up with the same problem that we can't recruit to these posts. So why don't we start thinking differently about how we do this and offer them as as secondment training, beneficial things in a different way, so people can go off and use money to backfill maybe some of the staff, or I don't know, I'm sure there's other ways of doing it. I just think we need to perhaps think a bit differently about how we approach, instead of applying the same approach we've applied historically. That's why I would ask. So 2 parts really.
Could I ask Dolores to come in? I think she's worked very, very closely with the providers and probably can answer some of the points that you've raised, Suzanne.
Yes. Perhaps firstly, if I can just reassure Leslie that I think to begin with, the pulmonary rehab was seen as the way to go, and increasingly it's known that that's not the only issue, and fatigue is a much bigger issue. The way we're set up in Cheshire, our providers of pulmonary rehab started doing the work and have seconded people with the appropriate skills to start seeing the people with long COVID who are referred back from the Liverpool hub. So they are probably the people who've got the most expertise at the moment, and have kind of started developing that expertise over the last 6 months or so. So the idea is around building around that sort of initial part of the team that we already have in place and that expertise, and building into that occupational therapists with fatigue management, psychological help, speech and language, and all of the other things that are required to support people with long COVID, as well as a third sector offer. So, and in answer to Suzanne, you know, staff recruitment is a huge problem, and people with these very specific skills are hard to come by, and the whole of the Northwest is fishing in the same pond for these staff with these specific skills. So what we have sort of had in our initial discussions with providers is that we do exactly what you say. We're probably going to second people with the specific skills and backfill them with the funding, with staffing with more generalist skills. So those are the sort of initial conversations we've had about how we can make this a really effective service for the people of Cheshire.
Thank you very much. I'm going to try to take some questions quickly. So some important questions being raised in the chat box. So Dan has raised, are we confident that the local service will be as high a quality as the centralised Cheshire and Mersey service? And Peter makes an important point about a clarification around the allocation. She says based on population numbers, is that per head, or is that per prevalence of long COVID in those areas? And Peter's raising the point about not exacerbating health inequalities. So if somebody could address those 2 points, that would be great. Thank you. Dr. Calvin. Okay.
Sorry, I don't know who's coming in there. Dan, absolutely. I think there's going to be, you know, like any service, I think there's been, to be perfectly honest with you, I think there's been a reduction in referrals from our areas, our places, purely through distance. So remote assessments is one thing, but I think actually what we're hearing now as well from patients, and what really is important, is some face-to-face assessment and real functional assessment for patients, and that can only be done locally. So we're going to be learning, and we're learning as we go. We've created a fair bit of expertise on this nasty disease in the last, 18 months, and we're still learning. So we are confident that we've got the expertise locally to support the needs of patients, and we're still learning on that one. So, but I'm encouraged it's the right way, it's the right model to be done rather than centrally based ones. But thanks for the question. I think more broadly when it comes to this, and we see numbers and allocations, I think as in everything, we need to actually meet the needs of patients, and not just the needs of patients in Cheshire, which is what we're interested in, but also Cheshire and Merseyside, and we've got responsibilities for that too. And if there is prevalence and we are managing health inequalities, we need to put our investment in those areas of need. And I think we need to look at that. As it stands, we need to be, our commissioning also needs to be data driven. So if the numbers are accurate and we do support that, then actually we need to invest those services in the right places. So I would support how we meet the needs of the population, both in Cheshire, but also in Cheshire and Merseyside. I think we've got a responsibility to our partners and our patients more widely to do the appropriate thing.
Thank you very much. I realise that there are other comments in the chat box, but thank you for those. But I think we need to move forward. So if we can go to the recommendations, Linda, I might come to you because I think you've made a slightly different ask in terms of funding. So the recommendations as they stand are note the contents of the paper and improve option number 1. But you've made a comment about funding for next year. I've got a suggestion about how we take that. I don't know how we deal with that. Can we borrow that? That's next year's budget. And
I'm only suggesting that we would guarantee additional funding into next year to ensure we get the staff into the service. Otherwise, we won't be able to deliver the service at all. And it's whether Dolores thinks that would be a useful suggestion, that we say that we would make available £607,000 again available in 22-23 to ensure that we have a service. Because if we can't appoint the people to what we're supposed to be doing for a long COVID service in this year, because the funding is non-recurrent, it makes a nonsense of the whole thing.
Yeah, so, you've made that. We know that. So you're essentially suggesting a 2-year contract. Is that something Dolores would be helpful, and can we take that as a recommendation?
Yes, and I think that would really help the providers have assurance that they could recruit permanently rather than on temporary contracts and secondments.
Okay. Can I also suggest, Andrew, that where there is slippage, that we take it potentially through something like the A&E board, because obviously long COVID is affecting all of the people in the system, and the A&E board is a place where there is a system view. And if there is slippage on this, or the service needs to be reviewed, that we take it to the A&E board, and that Claire Watson and Neil Evans, who sit on the A&E board, would have delegated power from the governing body to make any decisions around that slippage.
Okay. Sorry, we're adding quite a few additional recommendations to the paper, which is making it slightly complex. And I wonder whether do we need to do that last bit? So let's take we're asked to note the contents of the paper. We're asked to approve and recommend option number 1. So I'm looking for agreement first that we're in agreement with option number 1, which is delivery of a local service. Absolutely, I see agreement on that, and importantly, no disagreement. There is then the question on authorisation of essentially saying that it should be a 2-year offer rather than a 1-year offer, which will be binding our successful organisation to a contract for next year. Is that something that we wish to do? Are we content with that?
Yeah, just chip in a caveat with that. The proposal, or the possibility at the moment, is that funding would be 50% next year from Cheshire, as I said, with the assumption that the numbers reduce or the requirement for the service reduces. So I think yes to a fixed a 2-year contract, but we need to feature some review of what's within that, because it is unknown what is the requirement for this service and what staffing requirements we will need. So I think it just needs some flexibility that we review what is actually required in terms of that. So I'm saying yes, but, and yes, and to that, if that's okay, Andrew.
Okay, thank you. An even more complicated proposal for our recommendation. Can we agree as the option 1? What is the timescales then? And presumably you need to go ahead straight away, but then we can come back to the governing body with a proposal around how that works. I feel it's a little bit off the hoof to start changing the recommendation to being 2 years and changing and reviewing. Claire.
Sorry, I think what Tracy said in terms of ICS funding stands. But I think if we come back and wait another month before we speak to the providers and say, please go out and recruit on a recurrent basis, it will put pressure on the recruitment and the service implementation. So I think there's probably stuff behind the scenes in terms of allocations and review but we look at it as a 2-year ask of our providers, and I think we'll get a better take up and a speedier implementation.
Sure, well, I'm not suggesting that we delay it. I realise that there's urgency to this and we can't delay it. It's slightly frustrating if that was the best way forward. That's not the proposal, that we've got a different proposal that we have to change on which makes the governance difficult. So I think we are agreeing to option one, and we agree. I don't think anybody's dissenting to the idea that we need to make this a contract which is long enough and the commitment long enough for it to be supported. So I think people are saying 2 years, and then if you can work on that behind the scenes, I think that's helpful. But thank you very much, everybody, for that input into that, and thank you very much for Dolores and Amanda for joining us. Thank you very much. You might be staying for other ones. I think Amanda certainly is staying for the next one. So thank you for that. So that takes us to 4.3, which is the Ageing Well Strategy National Service Development Fund allocation on page 107 of your pack. And we are now further behind on our agenda. So again, colleagues will have read the papers, and if contributions can be to the point, please. Thank you.
Thank you. Same format if we can, Chair. So this paper, I will assume you've read, is very much guided by the National Ageing Well programme and the guidance that we have, and the service development funding which has been provided to the tune of 3.6 million for Cheshire. There are two aspects and two decisions that we need to make on that, we are focusing particularly on the Community Crisis Response Service. There are 4 options in the paper, but we are recommending that we allocate funding on a place basis so that partners can then allocate the funding within their place to deliver that enhanced 2-hour response service for the Community Crisis Service. There is also an element in there around enhanced health in care homes, 2 options there, and we are recommending that we allocate funding based on the care home distribution. Again, LMC have seen paper and are comfortable with what's in there. That's the endorsement that we've received. Healthwatch and the third sector have also been involved. Welcome to Bernadette Bailey, who's been involved heavily in the construction of this paper and is also joining us to answer some questions. I think it's probably best if we go into the debate and recommendations, Chair, in the interest of time.
Thank you very much. I'm pausing now because I think you've shocked everybody, Tracy, and now nobody's typed. So we'll just wait for people to type. Or perhaps there are no questions on this. I thought there would be. Leslie. So Leslie, and then I think Claire wants to come in as well. So Leslie.
No, it's just some clarification really on I suppose the care home SDF enhanced care. I suppose it's whether I just feel that it's quite high level providers rather than community based. Obviously, I know CWP provides community care, and whether the PCNs will be involved in this, because obviously they have control over the LES and the locally enhanced service and the direct enhanced services in the area, and have a lot of expertise of their own care homes in the area. So basically my question was sort of a bit of clarity around who will be providing that service and whether they will be looking at sort of involving the PCNs in that work.
I'll invite Bernadette to tell you the discussions that she's had around this, if that's okay. Do you want to introduce yourself, Bernadette?
Yes, Bernadette Bailey, Programme Lead for Living Well for Longer. And yes, as Tracy said, very involved in the paper and the work that we're doing on this. Our view is that this absolutely needs to fit with what's there already in place, and the PCNs and the care communities. What we're trying to do is add it to existing services rather than create something separate and different. So the aim being that we put some dedicated resource into those care communities, but probably with some specialist nursing. We're just having the discussions exactly what would be the requirement, and some discussions about what element is general nursing and what element is perhaps some mental health nursing, particularly as many people in care homes do have a range of dementia. So that's the discussions we've been having. We need to move quickly with all of these, and so the expertise and infrastructure around community services is with the 3 existing providers, but very much as Leslie highlights, the need absolutely to work as an MDT with the GPs and pharmacists who are providing the input into those individual care homes.
Thank you very much. Thanks for that answer, Bernadette. Linda, you have a question, please.
So it's in terms of, this is a considerable amount of money to be spent in quite a short period of time. So a note on the thing, it says unallocated funding will be assigned to key projects that support this agenda. I would like to know how we are going to make the decisions around how any unallocated funding or slippage will be assigned, and which key how will we decide what those key projects are? Which governance route will that go through, Bernadette?
And before we do that, can I add, there's a question, a comment from Peter making a suggestion that perhaps any unallocated funding should be returned to the CCG central pot.
Can I just say I'm really concerned about that, in that we do need to spend this money on these services in terms of ageing well, and I think we need a really slick way of making sure that we're applying any slippage or any unallocated monies within the system, because this is a key support to winter and to the urgent care agenda.
Thank you. I'll come back to Peter if he wants to come back on that, but I think Tracy, you were going to come in.
Yes, so the discussions on both this paper and the prior paper have taken place with our providers, and we want to support them to recruit the staff to deliver the service. Where that's not possible, there will be discussions about whether agency staff will be used. There'll be a cost. Where there is no staff in post, then the CCG cannot fund a service that is not in place. And so the governance route would need to be that we need to move fast, as Linda said. So we either would use execs or A&E delivery board to agree that in line with the requirements that are in those papers. So I think that would be my suggestion, that makes sure that it's transparent but enabling as well.
Lovely. Thank you very much. Peter, did you want to comment since I took away your voice?
No, that's I suppose it's fine. It's just it did seem a little bit imprecise to talk about key projects, and I think a little bit more precision about obviously you've got the process identified in terms of the exec team. I think you said an exec group to do it, but it would be a little bit. I was just unhappy with the word key projects. And I think, as Linda said, the same, that it gives discretion to whom to identify what those key projects are. I mean, you know, if it said assigned to other ageing well projects that support this agenda, would be adequate, I think.
Thank you. Can I bring Fiona in, please? You've got a point of clarification, and then Claire.
Yeah. So. It all on paper seems like all a very good idea, but it's about the funding really, because I know we've talked about this before about funding. Are we able to guarantee funding for next year when we're not actually going to be in existence? I'm assuming that's okay. And then it's you know, again with sort of with the workforce, but I was unclear about who the crisis workers were, who's getting the money, and who are those people? Are they care staff? Are they health staff? Are they social service staff? Because to me, one of the big things is that to our crisis of people who are actually in their own home, as opposed to health or old people's homes or residential homes, because at least there's somebody looking at them and assessing all the time if the crisis is escalating. But when people are in their own home, time is often of the essence to avoid ongoing referral into A&E or that sort of thing. So I wasn't clear who was getting that money and what they were going to be doing with it.
I'm sure Bernadette can give some information on that.
Yeah, happy to respond, and very pertinent question, Fiona. The service is predominantly focusing on those people in their own homes and very much avoiding a need to attend A&E or to avoid GP attendance. So what it is about is a team approach to actually respond to that, and the key parts of that team will probably be nurses and therapists with enhanced levels of skills in the first response. we've got proposals from the 3 sort of provider systems across Cheshire. They do vary a little bit because what they want to do is to add it to their existing services as opposed to setting something up that stands alone. So it is robust, because as well as the 2-hour response, of course, the next stage is the wraparound care, and critical that we can provide what somebody requires to support them to continue to live well at home wherever we can.
Thank you. Can I bring in Linda?
So can I just ask a follow-up there about NWAS then? Are NWAS being involved with this? Because they're often asked to come and pick people up, and they're very you know, they're very under the cosh at the moment, aren't they? And I know from personal experience with my in-laws, sometimes the waiting time is a very, very long time. While if the crisis was generated by a fall, you know, a single nurse, GP or anybody else is not going to be able to actually sort out the immediate crisis.
But yes, Fiona, the main source of route into the service will be through 111, and so will fit in with that whole centralised approach to ensuring somebody gets to the right service as quickly as possible to support their needs. Can I also perhaps just add, because you touched on social care. Social care is critical in this, as all the package of care is for somebody. It is very clearly badged that this is health monies at the moment, but discussions are absolutely with both councils, and they're both participating in the project group that we've set up to work on this.
Thank you, Bernadette. Linda, do you want to respond to the multi-year funding question? And then we've got some other queries.
Okay, so this is service development funding, which is non-recurrent in year 1. I think it's always expected that this funding will then be made recurrent in year 2. Given the type of service and the national requirements around this, I think that is absolutely appropriate. I have also checked with my provider colleagues, and they are also very much of the opinion that this service needs to be funded on a recurrent basis in order for it to be implementable. In terms of moving forward into the ICS, we will be writing something called a due diligence report, where we will be putting in all of the decisions that we are currently making that will tie the ICS into any investments in 22, 23, or indeed into any period going forward. So they will be fully aware of this. And I will also be making, I think probably on a monthly basis, my ICS colleagues aware of this, because I think it's something that we need to start building up for the Cheshire and Mersey ICS plan, which will be at an ICS level and also at a place level going forward. So I think this will form part of the 22-23 planning as well.
Thank you very much. Claire, can I bring you in, please?
Yeah, just very briefly. So thank you. I think any slippage on this scheme and the previous one, it's all about urgent care pressures. And I can see Neil's typed in the box as well in terms of non-recurrent, but I think we have two developing winter plans, both places, and there are a huge number of initiatives within that. And I think any slippage in terms of initiatives, we've got a menu of pressures that you know this sort of slippage would be well received. So I think there are schemes, Peter. I think in terms of governance, myself and Neil sit on. I chair the A&E Delivery Board. Neil sits on it as lead manager. So we could do it through that in terms of the wider system, which I think would probably be good practice, and then report back through execs. I'm just to say I was really supportive of giving the money to the existing providers around the 2-hour community response, but I would be really interested to understand how the current ICPs support and coordinate that, because that's what I see as a key role of ICPs or integrated place-based collaborative in the future. So would like to understand, maybe not now, but going forward, just how they play a coordinating and role in that delivery. Thank you.
Thank you very much, Claire. I'm going to bring in Leslie as the last question, then we'll have a response, and then we'll take the recommendations. So Leslie, please.
No, it was just a comment about the providers, really. I was just again about the fact that I have concerns about it being quite sort of hospital led, and actually a lot of this is seems to be community sort of crisis that I don't know whether we're looking at things from the wrong end, but others may disagree. So it's just really concerns about it being the right place, and actually a lot of that work may then impact on the community services and primary care, and actually there'll be no money for us to help in the community in the PCN. So I just feel that, you know, that the workload will eventually be pushed to us, you know, when they finish their crisis management, that these patients then have to be managed with us, and where does that help come? So.
Can I just come back? I'm sure Tracy or Bernadette will. I mean, this is community response, 2-hour community response. The funding is going to the providers because they are the host organisation. They're the sort of contract holder of the commissioned service. But this is absolutely 2-hour community response. So it is, the services will be provided in the community. And as you can, I think it's clear in the paper in terms of that MDT approach. So we've heard about MWAS, we've heard about social care, we've heard about community and primary care. So I hope, Leslie, I mean, if you're not assured, we need to look at that. But the money will go to the sort of the providers because they hold the contract, but the services will be delivered into and through the community. So I mean, that's absolutely clear, and that's clear from the national specification. That's what we have to commission.
Has that answered the question, Leslie?
I suppose it was partly more related to also the enhanced care funding as well. So, but yeah, that's fine. I can go offline and have a conversation. That's fine.
Thank you. Neil, you tried to speak in after I said I wasn't going to take anything more, but
no, it was a direct response to Leslie's question, and Bernadette's aware of this because she was present. I bizarrely queried the point you're making, particularly around primary care, at a recent meeting with some of the GP leads from Cheshire East and Cheshire West. And interestingly, they were the ones who answered the question rather than Bernadette, to say they felt really reassured that the specs that were being developed by the community providers with Bernadette actually worked hand in hand and helped general practice. And they gave me some examples in pockets. One was Ellesmere Port and one was over in the east of the patch, where they'd seen a really positive relationship between general practice and the community teams as almost pilots for this, and it worked for all the good of patients and the good of the system in terms of helping work together as a multidisciplinary team to support patients. So as I say, it's slightly odd that I was the one and GPs were the one assuring me, but they you know, the people who've been involved on the ground did feel really confident about this.
Thank you very much. Let's move to the recommendations. Thank you for the debate on that from everybody. It's 4.3, page 107. The recommendations to us are on page 108 are note the contents of the paper, which I'm sure we can do. Approve the recommendation for each priority area, noting that the funding will be made available once staff are recruited. Unallocated funding will be assigned to key projects that support this agenda, which we've debated and elaborated on. Approve a recurrent investment into the Ageing Well programme services, noting the cost pressures for the Cheshire and Merseyside integrated care system from April 2022. Are we in agreement to those recommendations? I'm seeing nodding. I'll pause to see whether there's anybody who wishes to disagree. I don't see that, so we will take that we have agreed with that. Thank you very much. Takes us to 4.4, which is remote monitoring / telehealth proposal for investment, page 121. Tracy, we're overworking you, but it's you again.
I like it, don't worry. So this is the final of 3 papers. So we've got Amanda going to give you a very brief overview, and I think we've got Alison Johnson also. Perhaps we can hear her but can't see her if there are any questions as well. Over to Amanda.
Thanks, Tracy. So my name is Amanda Ridge. I'm the Associate Director of Strategy and Partnerships. I'm very aware that you're running over, so I will be really quick. So in terms of this proposal, it comes out of the national mandated oximetry at home service that was provided during COVID. It's now extending that to long-term conditions. As Tracy described before, the paper's been reviewed by the LMC, who are supportive of the proposal, by Health Watch and by the third sector voluntary organisations. So the project proposal is to expand the current service, the oximetry at home service, to include long-term conditions, so COPD and heart failure, and to have an 18-month pilot. This has been very much directed by Cheshire and Merseyside. The other CCGs across Cheshire and Mersey have already implemented this, so we're the final CCG that needs to do this. We have funding that's been allocated for this year. There is an opportunity next year for some of the funding to be provided by the ICS, but there is a potential shortfall. We're looking at alternative investments, but we haven't finalised them yet. So that's where we need the governing body to approve that. And again, it links to the previous conversations that we've had about funding for 22-23 and the impact that that will have on the ICS. In terms of where this is going to be delivered from, the paper talks about Merseycare. That's how the other CCGs are providing this. We have been in discussions with local providers, and at the time of writing, the local providers didn't have the appetite to do this, to come up with a local model, but they have since expressed an interest. So Ali and the team will be having conversations locally to ensure that if there is an alternative model proposed, that it still fits in line with the timescales that we require and the budget we require. So those discussions will be taken offline. I think that probably covers it. I don't know if you wanted to come in, Andy, or whether you just want to go straight on to questions in light of the timescales.
Just that this we've seen how this technology, very simple technology, saved lives in COVID. The silent hypoxia absolutely saved lives, both in my family and also in my patients. So I'm really keen on this. We're extending this out more. We've talked about telemonitoring and telehealth for many, many years, actually. I think it's time we actually adopted some technology, and we can see that patient outcomes are better. And it's not just monitoring and actually seeing, you've actually got some clinical support to have this. So you can't just rely on technology. It needs the clinical expertise to support the technology. And I think that's key in making a successful program. It will also help discharges too. So having the confidence both in primary care and secondary care to adopt this and have that shared program is key to actually managing these very frightening clinical conditions, to be honest with you. You know, so when you are got heart failure, you have got respiratory conditions, it can be frightening. It actually does give some patients that reassurance when they need it. But key to this is how it's constructed. It's not just about the technology, it's about the staff supporting it too, and making sure that the selection is appropriate too. But yes, absolutely would support this development.
Thank you very much. I'm going to bring Gwydion, if I may, and Gwydion's made some comments supported by Dan in the text box, and I know Gwydion's done a little bit of work around this. So Gwydion.
Thanks, Andy. Gwydion Rees, governing body GP. I think the first thing to say is the questions I've got are no means a criticism, and I understand that doing any sort of research during COVID is challenging and the picture is moving quickly. I think the idea is sound. It's just that there have been a number of interventions during my career where the idea seemed sound and the outcomes were not as large as expected, or the outcomes were not actually as expected. Just at the paper that I've read, there are some concerns that I have about the study. So the fact that the study wasn't peer reviewed doesn't help. I've put some in the comment box, but essentially odds ratios in general are really difficult to interpret. It's hard to know what benefit you're actually getting with an odds ratio. The other thing is that they don't seem to have taken account for confounding. So confounding is where something else gives you the effect that you see, not your intervention. So the intervention that they're looking at is this pulse oximetry, but it might be that the other group are older, or the other group have more disease, or the other group have some other exposure or problem that gives you the worst outcome. The table is wrong in the paper, so the percentages are wrong. If the basic table 1 in a research paper is normally what everything is based on, so if there are inaccuracies there, they translate throughout the paper. So as I said, because in the non-monitoring group they were older and there were more men, we would expect them to do worse. But that's not to say that the actual finding isn't correct. And I was wanting to know, really, have we asked anyone in the academic clinical research networks to look at it? Because it might be that there were lots of limitations in the data collection and the analysis during a really difficult time. And it might be that the answers are correct, but the size of the answer is wrong. Yeah. Because then we could actually decide, does it work? Yeah. And then that sort of translates into the case for change, really. So, you know, we're hoping that it will improve outcomes. We're hoping it'll reduce admissions. We're hoping it'll have less NHS 111. I'm not debating that it won't, but I don't see the evidence for it. And then I don't see how it will do it. And then the other thing is, if it's a pilot, how are we measuring the outcome? So how are we seeing that it works? Yeah. So I agree with Andy. You know, there are obviously massive problems with silent hypoxia, and there are big advantages to telehealth. I just felt that with the data that I saw, I didn't see the justification for that. Thanks.
Thank you very much. I'll ask for a response. I wonder whether you're recommending the involvement of the academic health science networks and perhaps calling on some of their expertise potentially, but is there a response from the team on that? Yeah,
so thanks, Gwydion. I think the key is in the title, with it being a pilot. So the whole idea of the pilot is to test that proof of concept. So absolutely take on board in terms of we need to get more peer review, and what Ali can do. She is on the call. I just don't think she can be seen. But so with what Ali can do is link in with Cheshire and Merseyside, because it's very much been led regionally. And as I said, the other CCG areas have already implemented this, so we can already start to learn from them. They're a little bit ahead of us. But I can find out what the evaluation process, because it needs to be robust in order to measure it across all of the 9 areas. So I can find out what that is and feed that back to you offline, if that would be helpful.
I think it just might be a paucity of information within the paper itself, to be honest with you. I think that's quite rightly as a clinical, you know, appraisal of this in your position. You're absolutely right to actually question whether there is enough evidence base to actually support public money. There is huge amounts of studies done this on over 15, 20 years. I guess it's building on the opportunity that the COVID pandemic brought to actually bring technology in its bulk into the community and how we can actually utilize that opportunity. But I think it's right to actually bring in academic rigor to this and actually see what other evidence base we can to support it, even though it is going at pace within our own region.
Lovely, thank you very much. Can I bring Leslie in and for a question, please?
Yeah, so I suppose I do agree with telehealth, and I think it is a good idea in general. Works very well for COVID, given that often the admissions are related to decreased oxygen levels and saturations. My concern is possibly does work for COPD exacerbations. I think that's probably a good area that it works, but my concern is that actually heart failure is very complicated. Usually very elderly patients suffering with it, and it's not just about oxygen levels. Often it's about weight changes, and this has been tried to be implemented in West Cheshire before, and actually the heart failure nurses struggle to get patients to actually engage in it, because actually they weren't necessarily unwell at the time that the triggers come into play. So it is more, I'm probably not explaining it very well, but heart failure is very complex. I suppose I would want reassurance about the sort of funding this long term, that I would want, like Gwydion, that it is creating the outcomes that we would want for patients, and that it's not just looking for a quick fix for hospital admissions, really. So I suppose looking forward in the future, kind of financially, that I'd want reassurance that this is the right way to go, really.
Okay, Andy, do you want to respond? And then we've got a question from Dan, and then we're going to close.
So it's using technology as a key adjunct to care, not as the sole monitoring device for care. And I think that's the key bit. And it's how you educate patients and then bring them into this type of technology. So if they are having symptoms, not to ignore the symptoms, because the saturation still seems to be the same. It's actually just an adjunct, and that's the key bit. So it needs to be clinically, good clinical selection of patients is key, and actually to make sure they understand that, but not completely rely on that. And that's key to it, really. I don't want this to be the pulse oximeter service. It's not about that. It's just an adjunct to better care for patients in the community.
Thank you for that.
Hello. Just one other comment, picking up on the heart failure.
We need to be really quick, Amanda. We really are struggling for time, so just really brief.
Yes. Just to say, it's got much wider, you know, it can be much wider. So this is almost to test it, and we can then move on and look at other areas that are more appropriate. Sorry, Andy.
Yeah, no problem. I just don't want to get into a clinical discussion about it too much. We've got to make a decision at governing body level about this rather than Dan. What's your point?
Yeah, very quick. Dan Howcroft, secondary care doctor. I think it's just following on a bit from what Good is saying, but I'm not clear on really. So overall, I take everything, all the concerns, notwithstanding some of the concerns, but overall supportive. This is the way we're going to go. My big question really is that I don't think I can see in here what the sort of idea of what success looks like for a pilot, because of my concern with pilots is they just start and there's not really a clear endpoint where we decide whether it's working or not, and that's what's missing from the paper as far as I can see. And I think we need to know that, because we need to know that at a point in time we can say yes, this has worked, or no, it hasn't. And I guess that's the bit that seems to be missing at the moment. That's all. Thanks.
Sorry. I think that's a point really well made. Let's go to our recommendations, and perhaps we can amend them slightly. So I think we could perhaps make a recommendation back with the team, can't we? This is a Cheshire and Merseyside level proposal, isn't it, that we're fitting in with. We've been recommended to note the paper to approve recommendation option 2, and Amanda, I will ask, is that provider specific, or is that to go with a provider rather than buy licenses? We go with option 2, because you said that you probably a reconsideration of more providers coming in as options.
So the licenses have already been purchased by C&M, so that's a Docabo. In terms of how it's the clinical hub model is where we're looking at. We either use Merseycare, which is what all the other CCGs are using, or we could potentially look at a local model, but that's still to be explored with our local partners.
Thank you. So if we go for option 2, you still have the option to choose a different provider if that is available and thought to be the best thing to do. Yeah. Okay, so we're asked to do option 2. I think what we're saying is from the governing body, we're asking to have some consideration about the pilot and how it's evaluated, and that might need to be fed into Cheshire and Mersey level if that's the way it's going to be. But I think that's the recommendation, that our evaluation is, can we get the academic health science network or somebody involved to help make sure that this is a robust pilot and has the right evidence base. And I suppose that has to be done at the start, otherwise the correct data won't have been collected in order to get to the robust conclusion. So we've noted the paper. We're been asked to approve recommendation option 2. So I'm looking for agreement for that. Yep, I'm seeing that approval. Is anybody not happy with that position? No, thank you. And we're asked to approve in principle, the Cheshire Clinical Commissioning Group would fund any funding gap for 22-23 to enable the project to continue. Yep, that's required prior to the pilot project commencing. And again, I'm looking for approval for that. Yep, I'm getting nods again, and anybody not wishing to agree? No, thank you very much. So thank you very much for the team to work on that, and we've approved the recommendations in that paper.
Thank you.
Thank you. That moves us on to 4.5. Which is on page 137 of your pack, which is integrated care system design framework guidance establishment and governance arrangements for Q3 to Q4. There is an awful lot of this. Colleagues have had the opportunity to read it. I'm not going to say that that colleagues have read it all, because I doubt if many have read it all. But given where we are in time, colleagues will have the opportunity to catch up. It's a great place to have all the guidance in one place. But I'm going to hand over to Phil and Matthew and ask for brevity on this item, please.
Thank you, Andrew. So again, Matthew Cunningham, Director of Governance and Corporate Development, and with me is Phil Macon, the Associate Director of Governance as well. You're absolutely right, Andrew. This is a comprehensive paper. You'll be glad I'm not going to go through 160 pages of it. But hopefully you recognise why it's comprehensive due to the nature of the ask and the implications of going ahead with it. I would like to say thank you to a number of you around the virtual table who've influenced this, and hopefully you recognise your feedback that you've either given through the Governance and Audit Committee meetings or through individual meetings or through when we've had meetings with GPs. So hopefully you can see where your feedback is being referenced within the paper, and if not, hopefully we can address that as well. You might hear me say more than once with this paper is that it's comprehensive, but it has to remain flexible and it has to be, remain nimble of foot, because there are a lot of parallel interdependent pieces of work going on nationally and regionally that will impact on this. So by no means am I saying this paper is the finished article, and it does need to be flexible to be able to be shaped to the changes that are happening. In a nutshell, though, what we're proposing here is interim sort of arrangements for the rest of the financial year for the CCG, and in effect creating 2 new committees of the CCG that will enable us to focus on making decisions at our 2 place levels, but also retaining certain responsibilities at governing body level and at primary care committee level. I'll be brief, Andy, because if it makes sense for you to do, I'll probably go through to the recommendations that I've pulled together and where that links into the paper rather than go through each section of the paper. But ultimately what we're asking of the governing body today is a number of things, really. One is to, in effect, approve the establishment of 2 new place-focused committees of the CCG and the authority that would be delegated to that, and noting, in effect, as outlined in Appendix 1, the areas that each committee would cover, as well as the governing body and other committees such as the Joint Committee. I would also want to just highlight, previously when we discussed this at our July meeting, we did talk about putting primary care commissioning functions into these 2 place committees. But subsequent to that meeting, we have had the guidance from NHS England saying that we can't do that. So we are retaining the primary care, or the proposal is to retain the primary care committee, because that is part of the scheme of delegation with NHS England. Governing body is also therefore asked to approve the draft terms of reference for each of these place committees. We'd also like to highlight that's in Appendix 2. Governing body has been asked to approve the recommendations around the disestablishment of some of the existing CCG committees and recognise where we're proposing to put their functions and their responsibilities into the new arrangements, and you will see that in Appendix 3. And linked to all of that, we're also asking you to approve the proposed changes to the CCG scheme reservation and delegation, and that's in Appendix 4, to enable these committees to operate. Now, technically, the governing body can make all of those decisions, hence me highlighting that within the report. However, a sort of a final point, and it's highlighted really on page 141 of the pack and in paragraphs 2.1, 2.2, and then 2.3, 2.5. These changes can be considered to be sufficiently material for you to consider that we need to, formally engage and approach the governing body, the membership of the CCG to seek their approval of that. And that's part of the ask of governing body today as to whether they agree to that, and therefore we need to progress that formal engagement and seeking approval of the membership for all of these recommendations. I've tried to highlight within the report in paragraphs 2.3 to 2.5 and subsequently 2.6 and 2.7 around where we feel that by progressing this doesn't pose any risks to the CCG in terms of delivering its business. If anything, if we don't progress on it, it might increase the risks for us to be able to manage our business and support the transition into new arrangements for next year as well. However, as I say, part of the discussion point might be, as a governing body, do we feel we need to progress this to the GP membership for approval? I'm sorry if that's very brief, Andy, but I've tried to cut down the time, so I'll take any questions on other areas that people might want to ask questions and queries on.
Thank you very much, Matthew. And my apologies to colleagues and to you, Matthew, because as I introduced this paper, in my head, I was introducing a different paper, which is probably why the introduction was so confusing in relation to this paper. So well done for ignoring that and carrying on with this paper anyway. Comments, questions? So,
Andrew, oh, sorry.
Yeah, go on, Claire.
Sorry, I'm having problems typing in today. So I'm going to say a couple of comments. So firstly, thank you very much for comprehensive paper. It's really helpful, very methodical if you work through, and lots of people have been involved in its development, both in terms of the writing and the thinking behind it. So thank you to everyone for everyone's contribution. But just for assurance, we have obviously discussed this in July and subsequent, we've had conversations with the ICS, with partners, with the LMC and with senators. GARC, as Matthew said, and our governing body, GP. So I think it's important to know there's been lots of people involved at different stages of its development to sort of seek advice and guidance, really, in terms of getting the recommendations right for today. Unfortunately, because of the 4-into-1, we're the only CCG that needs to do this across Cheshire and Merseyside. So this is consistent with the ICS roadmap. So it's really something that we need to do. And obviously we agreed to that in July, but it just sets out, I think, the risks and the mitigations, and that's really, really helpful and keeps us safe. So it keeps Cheshire CCG safe, but also puts us in a really strong position, I think, for the future in terms of the place committee, particularly in terms of the terms of reference, where we're looking at wider membership on the CCG Place Committee board. So I'm very supportive of it. I think we need to go to the membership to seek their support, because I think that's the right thing to do as a membership organisation. But I think there's going to have to be a lot of work behind the scenes. So I'm going to thank everybody in advance for their contributions to that work in advance. But I think this sets us on a good course for the next 6 months. But it absolutely is only transition governance. I think we have to remember that this isn't absolutely the future. This sort of gives us a good launching pad for April onwards.
Thank you, Claire. That's helpful. I know Wendy's got a complex contribution, but can I bring in Peter on behalf of the GARC, and then I'll come to you, please, Wendy.
Yes, thank you, Dr. Wilson. I need to say something on behalf of the Governance, Audit and Risk Committee, who had the pleasure of reviewing the papers in detail last week. I know the substance won't be of the papers won't be any surprise to anybody. We looked at things from two angles. One was the safety issue, if I could use safety in loose terms, in terms of governance and key controls, and also in terms of how beneficial it was in terms of the achieving our strategic objectives, being in line with our assurance framework, etc. I think, just to echo Matthew, we stand a much better chance of fulfilling what we're trying to do as a CCG in the last 6 months with this in place than doing nothing. Our view was, I think, that we're not required to consult the membership from any of these changes, particularly having retained the arrangements around the Primary Care Commissioning Committee. But given the the small p political issues and the issues of influence, and also the opportunities for the members to be reassured around aspects of this, and also to maybe even help shape some of the detail of it, I think it would seem courteous to go down that route, even though I don't believe it's an actual requirement. I do have just one thing though, and I'll be very quick about this. I know things are moving very, very quickly, and I normally like to give advance notice of any kind of tricky sorts of questions, but when I went through the terms of reference again, knowing that the other members of the primary care family, opticians, dentists, pharmacists, etc., are coming into the ICS fold, and by implication will probably come down to place as well, that we need to, I think we need to start embracing that element in our place structures, not to give people voting rights, but even if people are observers at our meetings, I think we do need to be reaching out to the wider primary care family in our structures, just to reflect what's going on at ICS level.
Thank you, Peter. I think that's a very good point. We'll wait and see if there's a response to that, Matthew.
So by way of response, I mean, I think the principle is absolutely fine, Peter, in terms of extending the invite for people to at least be observers, you know, to that kind of meeting. I think we just need to recognise a little bit that the suggested membership, you know, can be tweaked, but there's always the bit around who can vote, who can't vote. And by and large, it is reflective of what is expected of place arrangements from next year, but it doesn't completely encapsulate all, because there's a lot more in there around public involvement as well. But I just really want to focus on that. This is for this year, and I think that there has to be that kind of parallel conversation around so what comes into place from the 1st of April next year, of which maybe, you know, the wider involvement of primary care and other partners might be better suited for that rather than the next 6 months. But again, that's part for us to discuss as well. But now I've taken your point on that one.
Okay, Claire?
Yeah, I think in terms of the terms of reference, I'm really keen, and then we have that whoever sits on these place-based CCG committees are the CCG governing body, as is in the majority in terms of decision making. So I think Matthew's right. There would be observers, if anything. I would be looking at that wider membership as part of any sort of ICP integrated care partnership. In the interim, I think going forward in terms of delegated responsibilities from NHS England, their direct commissioning functions into an integrated care board at Cheshire and Mersey, still a lot of work to do, because that will be in 22-23. Absolutely support this sort of what you're suggesting, Peter, whether it's in this committee or whether it's in a more of a place-based wider sort of partner committee, and we can just work through that. But this is absolutely initially CCG business in place for the next 6 months. So it's just, you know, we've got to future-proof ourselves, but balance what's on the who sits where. Thank you.
Thank you very much. I think Wendy's point has been covered, so she's withdrawn her request to speak. I'm noting that both Linda and Dan have said that they're in agreement with the proposals in the chat, and I think Paula, you have a comment, please.
Thanks, Andrew. One of the things I was reflecting on is if you take the example of Quality Safeguarding and Performance Committee as a non-statutory committee being disestablished, and the proposal to make it a subgroup, as it were, to one of the place committees. It all makes sense to me, and I think the paper does a really good job of explaining it. But one of the things I was reflecting on is the benefits of when we've scaled up to Cheshire is actually looking at some of the information we consider around quality safeguarding and performance in the context of Cheshire. So you actually get to see and understand a number of providers as opposed to one. One of the things that I was reflecting on is we will have to learn, I think, to make sure we still present information with the context. If we start to slim down information perhaps into place, we will have to develop a set of skills to make sure that benchmarking is available, to ensure that people get that larger picture, because actually some of that speaks to the very reasons why we started on our journey to become Cheshire. So that was just something I was reflecting about. Is there's a development piece behind this as well as the governance piece in terms of thinking about how we present information. Thank you.
Thank you very much. If I can voice a question from Pam, which is there any reason why the deputy chair isn't lay? And Matthew may want to add, but our aspirations were essentially to make this as joint as possible with local authority. We wanted the local authority to take up the deputy chair position on these two committees. And our original thoughts were that might be an elected member. So you would be getting in, not lay, but an elected member. That may not fit in with what local authorities wish to do. And so I think, as Matthew says, we've built in some flexibility around that. Did you want to add anything on that, Matthew, or have I covered it?
You've covered it, Andy.
Yeah.
Is that okay, Pam? Yeah. Tracy, do you want to come in, please?
Thank you. It's just a question. I think that there's a lot of work on in here. It's temporary, isn't it? So I don't think we need to. I think it is very fit for purpose. I'm very supportive of it. I'm just keen that we make sure that we get closer relationships and build those with our community and voluntary sector, and wondered if they could be part of the membership under participants We have good relationships with several organisations that would be appropriate. And in view of the last papers that we've just discussed, I think they have a part to play in supporting our workforce challenges and our support for our communities. So I'd be really keen to see them included.
Claire?
Yeah, absolutely. I think that's a really good point, and it builds on what Chris Lynch was saying earlier in terms of the guidance that's come out in terms of that co-production and that wider engagement. You'll know, Tracy, that Gary Cliff has been invited to join the Cheshire West Place Executive, and I think that's the right approach in terms of place. So I think that's we can look at doing that in both places. So I think that's a really good call, and I'd be very supportive of that. Thank you.
I'd be supportive of that as well. So I think that's a great suggestion. Thank you. Thank you very much. So, are there any other comments? So, sorry, I introduced the paper saying can we be brief on it, but it's quite a substantial paper. It is, you know, a pretty big decision that we are taking here. So I am going to pause to allow anybody to stop, reflect, think, and ask anything that they feel they need to on this paper. Okay, in which case, let's go to the recommendations. Matthew.
There is another question from Pam in there.
Who is that?
I suppose I was going to say, Andrew, I said at the beginning, I'll say it again. These arrangements have to, remain flexible, because as more guidance comes, as more things start to shape at Place and at Cheshire Merseyside, we need to be able to respond and react accordingly without having to go through necessarily all the hoops we've done historically. So that's probably why you will see certain things in the terms of reference that aren't maybe as direct as you would have seen previously, just to give us that flexibility. I suppose one other comment really is that links to Pam's questions, is that in some respects this is CCG business, wasn't trying to replicate or replace any existing sort of place arrangements or give that interpretation in terms of, so what's the health and wellbeing board, what's the place executive. So, suggestions for more membership or observers or participants are great. And I think that's part of maybe the first conversation at these first place meetings around the table, rather than it being just the CCG saying this. It would just be my thoughts.
Thank you. And actually, Pam has put the question about the chair, the deputy chair, saying the paper says it needs to be a GP, which was not my understanding, but I've read so many papers and this one several times that I may have misread.
No, Andy. So I was basically saying in the paper that if you needed to have a deputy, a named deputy, it could be another GP.
Right, not deputy chair.
To be the vice chair, it would be flexibility. That would then retain clinical leadership.
Yeah. So I think where we got confused there is I was talking about vice chair, and you were talking about a deputy for me if I wasn't here, which we would seek to be a GP colleague, but the vice chair we're seeking to be somebody from the local authority. Yeah, and we're in the CCG, whereas we've had a requirement for, if I had to step down, for that to be a layperson because of conflicts of interest, that would be covered by the vice chair, I suppose. Okay, is that okay, Pam? Everybody, yeah. Right, thank you. So let's go to the recommendations on page 138, which are to note the work undertaken and consider the proposed arrangements outlined within the paper and supporting appendices, consider the recommendations within the report from the Director of Governance and Corporate Development, and agree a position. The recommendations outlined in page 13, page 154, are that the governing body approves the CCG Place Committee terms of reference. So I'm going to take these individually. So I'm looking for approval for the terms of reference. Yeah. Thank you. Governing bodies will approve the amended CCG SWORD and SFIs that reflect the establishment of the CCG Place committees. We content with those. Thank you. Approve the approach to continuing operations and the disestablishment of the named CCG committees. Happy with that. Approve the approach around the management of the CCG strategic and operational risks. and agree that GP membership is formally asked to approve the establishment of the CCG place committees. Yep. Thank you very much. We will do that. We'll take that forward to the memberships at the 2 place-based memberships, and then come up with a mechanism to do it across. Claire?
Sorry, Andrew, are we saying formally ask? Because I don't know, is that what Gark said? Because I support absolutely just having that conversation, but to formally ask, and I guess if they say no, I'm just understanding, we have to be careful how we ask then and what we ask.
So if we can remind ourselves of the situation on this, if we was to do it formally, so because the SORN is being changed, there was a requirement to change our constitution. So what we're saying is this within the gift of the governing body to change the constitution on this matter? Is strictly speaking on our constitution, can we do that? Governing body, of course, can, recommendation of Claire, and consider a change to the constitution. However, should the governing body, or should the GP, 4 GPs on the governing body, or should I believe that those changes are material, and there are some examples given in the constitution about what would be material, such as the change of delegation between the membership and governing body, then either the governing body or the majority of the 4 GPs or myself can direct it towards membership for their decision. So I can shortcut this because we can go through all of those, but in the end, I'm going to tell you that I'm going to use my vote and direct it towards membership, and I'll share with you my rationale. So yes, technically, it's within the gift of the governing body to set up subcommittees. But if you take a step back, this is about the membership delegate their responsibility to the governing body to run the CCG, but they do that on the basis of the membership and the what's within the delegation for that governing body. So whilst the governor could then further delegate it, I think that it's almost sort of disingenuous to say, well, that just because technically we can, that doesn't affect it, because you're fundamentally changing what the governing body does. And so I believe that we do have to go to membership. And that's my position coming into the meeting. I'm happy to have a debate about it, but
I mean, I'm happy with your recommendation. I suppose I actually agree we have to go to membership. I guess it's the formality of the ask, but I'm happy to take your lead on this, Andrew, obviously.
Yeah.
Andrew, okay. I think it's absolutely fine for the governing body to approve everything that you've seen today, and it's the recommendation to the membership for them to formally approve it.
Yeah.
We have the risk that they might say, what about this, what about that, and then we'll address that. But I think the recommendation from the governing body is in effect to support these changes.
Yeah, absolutely. And I'm happy with formally asking the membership. I wonder whether we should actually consider asking the membership whether they wish to give up their constitutional right to change the constitution, because I think we're going to be going back to them asking them for further constitutional changes, and they may well wish pragmatically just to give all of those rights to the governing body, as some of the CCGs do, and that might be something we wish to ask them at the same time, so we're not in this situation again, because I don't think this is going to be the most important thing on membership's minds. I really don't. There are much more pressing things for them at the moment, but I just think if you read through our constitution, I think it just leads you to suggest that it needs to go. And I realise Gark's position, but technically you don't need to, but I think you probably do. Okay, so are we content with saying that we are going to formally ask the membership for approval? We'll just leave it like that. Thank you.
Andrew, Peter's got his hand up virtually.
Sorry, Peter.
I'll be very quick. I think we need an effective date for the changes to be agreed here, so that we can actually get on with it. And now I realise that it's got to follow for no other reason than courtesy. It's got to follow the consultation with the membership. But we need to have an effective date, I think, for these recommendations.
Matthew?
Yeah, so Peter and Andrew, in the paper suggested that it is established we would look to have these meetings at the beginning of November, utilising existing governing body dates. So I would say our intent would be to establish this from the 1st of November, which gives us that period of time within October to do that kind of formal engagement with our membership, of which there are already dates in the diary to do that. The paper's already articulated how the existing arrangements of committees are currently being managed in interim or transition, which and some bits will be picked up by Cheshire Merseyside and some will from there. So I think if we could say an effective date, I'm going to say the 1st of November, but I don't know if that's a Monday, but I'm just going to say from the 1st of November.
It is a Monday. It is a Monday.
There you go then. Would you be happy with that, Peter and Andrew?
Yeah. Lovely. Thank you very much. Thank you very much. I think we've concluded that business. Thank you very much for that. It's a big step for us. I think it is a significant step forward, and I think it will be the right thing to do for our population to have that smoother transition in and help our places get the delegation. I think it's important steps. Thank you very much for that. Moves us to item 5.1, the report of the Joint Committees of the Cheshire and Merseyside CCGs, page 258. 137 from the original pack, apparently. So this is for myself and Matthew. You've had the opportunity to read the paper. I'll take questions, or Matthew will take questions on it, but I don't intend to read the paper out to you. Probably what you've got there is the minutes of the first meeting, which have been which were agreed, and then a report of the second meeting. That the minutes haven't yet been reported there. It's probably worth saying there were people present, so Suzanne was present there. There was debate about a number of the items there, which isn't necessarily reflected in the reports because there aren't any agreed notes from that yet. And if we were to sort of put that debate into that report, we'd be creating almost a second set of minutes. So we've deliberately not done that. It simply tells you almost what was discussed. We've heard the important thing about the joint committees, which is the consideration for increased delegation to the committee, which are the 9 CCGs across Cheshire and Mersey are now presently considering, and we're proposing a governing body of each of the 9 CCGs held in common early in October to consider that item, which of course you'll all be involved in. I'll take questions, which I may pass on to Matthew.
Andrew, I think it's probably worth just noting that the ask is for approval of the slight amendments to the terms of reference as it stands. You've covered, we recognise that something else might come back to the governing body in committees in comment in October that might further change the terms of reference, but the proposal now is only minor changes in terms of the terms of reference. But equally, I'm happy to answer any questions.
I should have said that. It's highlighted. There's changes in blue in the document, aren't there, which are changes to the terms of reference, but they're all minor. Okay, we're asked to note the report and the discussions. Are we happy to do that? And we're asked to approve the amendments to the committee terms of reference. As Linda's just typed in, the changes are very minor. Are we happy to do that? Thank you very much. That moves us on to 5.2, which is the Quality Safeguarding and Performance Report on page 284 or 163 if you're looking at the original pack. And that is, I'm passing it over to Paula, please.
Thank you. The report that you've got before you, if I follow the guide that Andrew's just given in terms of the joint committee, is that this is a report from the committee, Quality and Safeguarding Performance, and we did meet on the 1st of September. So the pattern and the routine that we have is quite often when you receive template reports from committees, it may be a couple of months in arrears, whereas we turn this around from the committee that met on the 1st of September. So not all matters that go to that committee are in this report, but there is a summary of those matters which Christine Morris, as chair, was asked to bring to the fore by the committee. There are a number of statutory areas within there that I would just like to really highlight in it. The complaints annual report from 2021, there's a link in there to the full report. I do think it's worth, as a governing body, being aware of the contacts that we did receive last year 830 of them, and that is an opportunity for the CCG to both listen, signpost, support, and I think anybody that engages with the CCG, it provides us with also a great opportunity to learn. When people come to engage with us, not only is it sometimes to express dissatisfaction or to ask queries, it is also as well, I think, incumbent on us to learn from those comments as well. There's also information in there where Neil and I interface between each other around where performance indicators may impact. So I will leave it there and just take questions in terms of time, Andrew, and taking your leave from the Joint Committee paper. Thank you.
Thank you very much, Paula, and thank you to yourself, Christine, for turning this around so quickly, because I think your committee was only a few days ago, wasn't it? So I'm not sure that I think somebody's probably lost sleep over it, so thank you. Questions, please, from anybody? Leslie, please.
Firstly, yeah, thanks for the report. Unfortunately, I wasn't able to make the last quality and safeguarding meeting, so these questions may already have been asked. So I suppose mine's just a general sort of feel for what's being commented on, that it seems to be that we have a system very much under pressure at the moment, and I've made that comment before, that obviously complaints are often driven when the hospital staff and services are under strain, and you don't have, people don't have time to explain things properly, and there's a lack of communication. But you're right, there is learning around those things and things that we can put into place to help. So I suppose mine was just really a comment that a lot of these sort of the trolley breaches, the impact on the system, it's all linked together, and seems to be that we need to just acknowledge that we were under a lot of pressure, and that is a safety issue to our patient population. But thank you for the report, it was very comprehensive, Paula. Thanks to your team.
Apologies, I was muted. Wendy, would you like to come in, please?
Yes, just to pick up on something that you said earlier, Andy, about GPs. And I was wondering, I enjoyed the report, and we are looking, as Leslie said, through some of the risks and problems within the system. But we don't really measure or report in that on the primary care area of what's happening there. And at the moment, there's a great deal of public outcry against GPs, which frankly we don't seem to be in any of these reports addressing. So I just wondered, have we got any of the actual statistics around the general practice pressures that they are facing and how they're being addressed?
Do you want me to come in, Andrew? Thanks. What it might be worth doing is just getting a perspective, I guess, from the front line. I'll then quote some numbers in terms of answering your question, because we do have a considerable amount of data. And one of the things, of course, that has been heavily publicised is this view that, and Andrew touched on it earlier, that general practice is closed to face-to-face attends. So just to quote a couple of numbers which give you a feel, more people are still being seen face-to-face in general practice than via telephone or video consults. In the last year, it's 1.85 million face-to-face appointments and 1.37 million telephone and video consultations. And obviously beyond that, you've got the vaccine programme that general practice has been heavily leading in Cheshire, as Claire touched on it earlier, one of the most successful programmes in the region. So lots and lots of contacts going on. But I wonder, Andy McAlvey, whether it's worth you just giving a bit of a perspective as a GP as well.
Yeah, I think any of the GPs on the call could wax lyrical about this, to be perfectly honest with you, but I agree. And Wendy, thank you for bringing the topic up. I think, the whole health system and the health and care system is under extreme pressure. And I guess some get more priority and more visual priority in press and media than others. I'm guessing that general practice, and I think my colleagues would agree, has less exposure than other areas. And agree, the national negativity is really unhelpful. It is having a detrimental effect on morale, on recruitment, and we're losing clinical and non-clinical staff, certainly in primary care, who are feeling undervalued by the public and by patients. And it's distressing that you can get one or two very nasty comments and it just affects the rest of your day. We are running a campaign though. We are doing stuff, and it's on some of the negativity, but actually the In It Together program that we're doing and actually constructed by the CCG is important, and actually to address that and to support practices who are actually having difficulty. We've got lots of different blogs, we've got video presentations from prominent GPs in Cheshire who actually to support that, to support the program of how difficult it is to managing in general practice at the present time, both from a clinical and administrative perspective. And just reiterating the different nature that we've had to involve in a massive vaccination program, conducting the bulk of the vaccination program, frankly, and actually that was whilst other things, contractual things, were suspended. We're now in a situation where the contractual situation is carrying on. We've got to carry on with other business as usual, and yet there's still some expectation to actually take on the booster program and other portions of the vaccination program, and the biggest flu vaccination program that we've ever undertaken. So it's challenging, and I think we are doing as quite a lot to actually try and stem that tide. I think there is escalation both to regionally and nationally to how do we try and address that. And I just, you know, huge thanks. I only work 2 days a week. They're full time. They're 12 hours a day, but I only do 2 days a week. It is exhausting. But actually, we just to maintain that focus and to maintain the resilience, and we're trying to do all we can to support general practice and in fact the whole system to actually maintain that resilience. But thank you for the question, Wendy. It's very welcome.
Thank you very much. I think Claire wants to come in. So Claire, please.
Claire, you're on mute.
You couldn't read that bit then. So first of all, I said thank you very much, Paula and Christine, for turning around. Really comprehensive report. I think it's helpful to see, you know, information about our main 4 providers, but obviously some of our other independent sector providers in terms of quality and performance issues. It would be interesting, as Paula said, reflected earlier, in terms of how this report is presented into the 2 place committees going forward, because there will be some work to do in terms of some of our providers cover both places, but I know that will be done. I thought also a couple of points. Yes, really helpful complaints and report. Thank you. I thought also just the enormity of work that goes on by the patient experience team, and probably isn't recognised and isn't, you know, it's one of those teams that sort of work behind the scenes, and without them we'd be lost, but they don't sort of probably get the profile they recognise. So I thought I wanted to recognise them in the meeting today, so thank you for that. So just say really good paper, Paula, as ever, and thanks to you and the team for the work you do. Thank you.
Thank you very much. So I'm just trying to keep up who's coming to ask a question. Pam wanted to ask a question. Pam.
Yeah, it's a comment really, because I'm obviously on this committee. I think that it's right to say that the committee were very worried, in fact very concerned as well, about the mental health investment, that we'd actually put more money into mental health, but we weren't getting the services that we'd expected from that, mainly due, I think, because there's staffing issues. And secondly, that although there is some improvement in the acute trusts and waiting lists, we were pretty worried about the enormous numbers of people that are waiting for all sorts of procedures and visits or appointments. And I think, although it doesn't say it in the paper, which I think is very good, thanks to Paula and Chris, that has a knock-on effect on what GPs have sitting in front of them. It must do. And the committee does recognise that that is something that's happening. So that ties in with what was said before, really. But there is a recognition in that committee that all of these waits and all of these delays are having an impact on general practice. I just wanted to make that point. Thank you.
Thank you very much, Pam. That's all very, very, very true. I can see there's been discussion in the chat box about the GP position, and I think Wendy's position was about reporting and knowing what the information we have about practices, and that's yes, that is in support of GPs, pointing out that the demand is outstripping the resources that are in. But it's also about ensuring that actually practices are delivering the resources, the service they can with their resources. It's about being confident about that side of things as well. So we have to be confident about that against our 80 practices, which I'm sure Neil is. Picked up from that, there is, I think Good has picked up what should we be doing as a membership organisation in terms of support of the position, and Claire has commented that she has been discussing that with the LMC in terms of some joint communication. So I think that's helpful to know, and I think will be appreciated, because I think Andy's points are very true, that talking a service down unfairly in the way that general practice has been talked down is demoralising and unhelpful, and does not help that service to continue to provide the service that it is. And what I tried to say at the start was there are many, many, many great stories about the care that is being delivered. What we hear is all the negative ones. We don't tend to hear the really positive ones, but they are out there. Right, thank you very much. Are there any further comments on that quality safeguarding and performance report? Don't believe there are. Thank you. We're asked to note the report. Thank you very much again to that committee for that report. If we can move to 5.3, well, can we take it? We're taking 5.2A and 5.2B together. We can. Thank you. And we can move on to 5.3, which is the report of the Finance Committee, including the financial updates. Can I pass it to Linda, please?
Dan, did you want to say anything?
No, it's fine. No, because I was going to take questions and hand over to you, so that's fine. You go.
Okay, thank you. So, as in the interest of keeping this brief, the actual update report is fairly consistent with the previous months. We are forecasting a break-even position for the first 6 months of the year. The significant risk to that is the unidentified quit, the savings that we need to make to get to that position. We are working across all of the CCGs in Cheshire and Mersey now in a collaborative way to seek a solution which will provide us all with a break-even position, and that's a very positive. Discussions are ongoing. In terms of the key risks for the remainder of the year, there is a lot of uncertainty still in respect of the next 6 months and the funding for the next 6 months, and we are awaiting guidance on that, hopefully today, early next week, but that is leading to, obviously, to risk because of the uncertainty involved. We still have increased costs around the COVID-19 and the impact that is having on the cost of services, and we also need to ensure that we continue to have robust financial control during the transition to the new ICS. So those are the things I would like to bring your attention to. Are there any questions?
Are there any questions? My apologies to Suzanne for not passing it to you first, Suzanne. Leslie.
Thanks, Linda. Another comprehensive report, but I just wanted to, if you could just sort of clarify or explain on page 313 the sort of forecasting to overachieve in the mental health investment standard by over £1 million. Can you just clarify that so we understand that a bit better? Thanks.
Okay, I will do my best. So this is in terms of the core expenditure by the CCG. So this is our recurrent expenditure on mental health services by the CCG. So we have over the past few years had a target to increase our expenditure, and we are exceeding that by £1 million. So we did have to spend 106 million, and we're actually spending 107. So we are exceeding our expenditure. There is additional funding that we are making available for more services this year through the Service Development Fund and through the spending review. And we are going to be in receipt, hopefully today, of a plan of how those monies will be spent by our mental health provider. And those monies do not count towards the mental health investment standard. Does that help? Thank you.
Thank you for that, Linda. Are there any further questions for Linda on that report? No, thank you. Suzanne, did you want to make any closing comments? Okay, thank you very much. Okay, so we're asked to note the committee activities since the last governing body meeting and to note in particular the issues outlined in section 3. Are we happy to do that? Yeah, thank you very much. We moves us to 5.4, which is the report of the Primary Care Committee. And just I will come to Pam on this occasion, just to make sure everybody's on the Pam.
Thank you. You'll see from the report that we have discussions on the extended access schemes, additional roles reimbursement schemes, some IT stuff, and our quality information. Well, we made decisions which you need to note. We approved the estates investment policy, which we've been waiting for some time. We approved a practice boundary change. We approved extensions to some alternative provider medical services contracts. And we approved an application from Danebridge to close its branch surgery at Sandy Way. So if anybody's got any questions, I'm quite happy to take those.
Thank you very much. Any questions for Pam? No? Okay. We're asked then to note in particular the items the committee wishes to bring to the attention of the governing body, which is section 3 of that report, and note the items listed at section 4 of the report, and that report is on page 316 of your pack. Are we happy to do that? I think we are. Thank you very much. That takes us to item 5.5, which is the report of the Strategic Commissioning Committee, and to Wendy, please.
Right, this was the last meeting of the Strategic Commissioning Committee, and there was nothing too onerous on the agenda, as you can see the items that are listed there. The IAPT one probably created the most discussion, and the committee did wish to debate a number of the items further on that, which is why it says it will be brought back to the committee at a later date. Well, obviously we won't be having another committee. And as you'll have seen in today's papers, the IAPT work has been discussed at the Joint Committee and various other areas. So there is no need for it to be brought back, as it will be, the issues that we identified will be handled appropriately. But unless there's any other questions on any of the other items, I'll leave it there.
Thank you very much, Wendy. Are there any questions on the Strategic Committee report? No? Thank you. And again, we're asked to note the report, in particular the items brought to the governing body's attention in section 3 and the items listed in section 4. Are we happy to do that? Again, I can see nods. Thank you very much. That takes us to section 6.1, which is the forward planner, which is on page 325 of your report. And that is there for your information and comment. So I'll pause to see whether there's any information or comments. I don't believe that there are, so that is for noting. Okay, so Fiona, you have a point going back a little way. Do you want to make your points and then before we close?
Hi, sorry about that. I don't know how I missed that. I just didn't quite understand. I know we've accepted it and that's fine, but just for clarity, In the finance paper, issues for escalation to the governing body, number 3, it says the finance committee will continue until December with a view to merge with the GARC from January. So that had passed me by altogether. So so is that a new committee? Who chairs it?
I'll answer that one if that's all right, Chair. No, Finance Committee is going to continue in its current form until December, and then the financial overview will transfer to GARC. That's how it's going to happen. It's not a new committee. It's just a function of finance will go to the GARC, and the other bits of finance will go to place, basically. Is that okay? Okay, thank you.
Lovely. Thank you very much. Lovely. Is that okay, Fiona? Lovely. Okay, thank you very much. I think that does take us to the end of our meeting and conclusion of our business. So thank you for your contributions and for your cooperation in me moving the agenda on. We have finished a little bit over, but far less over than I thought we were at one point. So thank you for your help and cooperation with that. And thank you for important discussions today and some very important decisions that we've made to move things on for our 2 places. So thank you very much. And I'll see you at the next meeting.
Thank you, Andrew.